And thanks so much, Cindy. We've had a great morning, starting with some patient stories, weaving in with the bleeding edge of what's new in sepsis, how to bring that research to the bedside from Dr. Bridges, who I always learn from, and then a very interesting discussion of fluid, which I thought was an amazing discussion because I think I have a better sense after our discussion about how to use fluid in sepsis. But this afternoon, we're going to bring it back towards our patients because I think that's who matter. And that's the reason we're all here to learn. A couple just quick reminders that we have a Q&A for questions. We have a team of folks that are going through questions, combining questions that are similar so we can ask our panelists. So please put your questions there. We also really believe strongly in the sepsis forum. So the chat is completely open. And people have been using that with some fun and great conversation during. So I appreciate that. We're going to start our afternoon off with two excellent presenters talking about sepsis survivorship. And this is something that, everyone has always asked about, and it's not something that I really know about being an intensivist and an ICU physician, but it's something that I get to experience when I see my patients back in the ICU sometimes, or if I make good relationships with their families and get to talk to their families. So there are two speakers for our sepsis survivorship panel are Dr. Liisa Holsti. I'm going to introduce both of them, and then I think Dr. Holsti will present first, and then we'll do questions to both of them after. Dr. Liisa Holsti is an occupational therapist and professor in occupational science and occupational therapy at the University of British Columbia, and an investigator at BC Children's Hospital Research Institute. Her program of research really focuses on developing ways to assess and support optimal development in high-risk infants and children. And I think she's a pretty humble person because this is the bio she sent us. It's pretty brief. So I did a little research and PubMeded her and found almost 100 publications, maybe over 100 publications. And I'm like, well, that's a lot of publications. But, my boss always holds me accountable to senior author publications now that I'm getting more gray hair, and well over 50, maybe even 70, I don't recall, senior author publications exploring how to better care for children in recovery. So amazing. And Dr. Mark Mikkelsen is Associate Chief Medical Officer for Critical Care at the University of Colorado Hospital. He serves as the chair of the Critical Care Clinical Outcomes Governance Group. That might make him the governor, I'm not sure, and the Sepsis Clinical Effectiveness Group. And this is a pretty high power group, right? This is Ivor Douglas, et cetera. So not easy cats to herd. During his career, he served as the chair of the Society of Critical Care Medicine's Thrive, supporting survivors of critical illness initiative, among many other key roles. As an expert in sepsis and really the life after sepsis, Dr. Mikkelsen has partnered with the Sepsis Alliance, CMS, state hospital associations, home health even organizations to improve care and coordination. And he'll be giving us some overview of some of his successes and maybe some opportunities. So Dr. Holsti, I'll let you share your screen and start us off. Thank you so much.
Thank you. All right. So thank you very much. Today, I'm very honored to be here and talk with you. One of the things I didn't say in the bio is that I worked clinically in the neonatal intensive care nursery here at BC Women's and Children's Hospital for almost 20 years, and also worked in the neonatal follow-up clinic. So I have a kind of perspective on child development from birth to early adulthood. So I'd like to start by acknowledging gratefully that I live as an uninvited guest on the traditional occupied ancestral and unceded territory of the Musqueam people. I pay my respects to all First Nations people and acknowledge elders past and present, and would like to acknowledge the funding for the work I'm talking about today. So the objectives that I set for this afternoon for my part of it is to describe the developmental impact of sepsis in infants and children, to describe the current needs to improve post-sepsis developmental care for infants and children. And then I'm going to end off with a kind of practical example of how I hope I'm contributing to that by describing the initial development of a neurodevelopmental screening tool for identifying infants and children at risk post-sepsis, with a particular focus in low and middle income countries. So I'm sure most of you know this information already, but there are over 4 million children who suffer from sepsis globally. And of course, the rates for sepsis are higher in low and middle income countries. And with advanced care, 80 to 85% of these infants and children will actually survive. And I put this last bullet in, but I'd like to put a caveat to it because we don't really know what the long-term permanent impact is following sepsis, but currently it looks to be about a third or a little bit more of children may be left with impairments in one or more areas of their development. So I'm going to go into this part of it in a little more detail and explain what it is that we do know. So areas where reports have been published on the impact of sepsis on neurodevelopment really is talking about a post-sepsis syndrome. And we see at the moment, long-lasting changes in cognition, motor skills, vision, hearing, and in quality of life. And with the limited information that we know now, the prevalence of post-sepsis syndrome worldwide at 28 days post-discharge is about 45%. And this is combining high-income and low and middle-income countries. I would argue, having worked in neonatal follow-up, that 28 days post-discharge does not mean long-term outcomes. In my world, that's very short-term. We have some data from looking at long COVID, and there are variable results in children with rates ranging from 1 to 47%, but we have a lot more to learn in this particular area. So if we focus on what we do know, in high-income countries, we actually have quite a lot of information, particularly on infants. We see that neurodevelopmental changes can persist well into school age. And the reason that we have this information, and this relates to things that we need to do in developing countries, is that we have comprehensive, multidisciplinary, multifunction assessment to school age, and in some places beyond that. In some countries, there are national standards for follow-up, and those include specific ages for testing, alignment of the types of tests that are used, and the use of centralized national research databases. And the Canadian Neonatal Network is one that's been around here for a very long time. All of those factors allow us to collect comprehensive longitudinal data on infants who have had sepsis in the neonatal period. The other part that we add to that strength is there are a number of community services that are available to provide ongoing developmental treatment when difficulties are in fact identified. And that varies in Canada by province, but there are many at-home programs, and there are already programs that are sort of center specific as well in communities. With respect to outcomes in children in high-income countries, a comprehensive long-term developmental follow-up is an emerging area of research. The Collaborative Pediatric Critical Care Research Network is an example of that. And from the work that is available, we find that neurodevelopmental changes and changes in health-related quality of life are seen in a third of children, and that these can persist for more than a year. The main issues with the data are that what is available tends to be from small regions within select countries. It tends to be shorter term, or it may be missing key aspects of development. So they might report on intellectual outcomes, but not report on motor outcomes. There may be reports on school function, but not quality of life. So in general, what I would say is that there remains a need for long-term detailed developmental information following severe illness in children. In low and middle income countries, we know even less. There are less than a handful of studies that talk about developmental function post-sepsis, and this is at around 28 days. In one study from a hospital in Tanzania, they were able to follow 4%, which is a very, very low number, of over 1,300 children. And 13% of the guardians reported that children had not returned to baseline function. But this is a very select group and a very small group. What we do know is that mortality is high, and so is recurrent illness. It is highly probable, therefore, that significant morbidity is very common beyond 28 days and is also very likely more common than in high-income countries. In general, there is a big gap in sepsis research, practice, and policy. And I'm identifying 4 areas that need work in low and middle income countries, but I'm going to focus on one in particular in just a moment. But we need more trained people who can identify and treat children who have neurodevelopmental delays. And I'm not talking about task shifting. I'm talking about skilled, trained individuals. We need more tools that can be used on the front lines to evaluate neurodevelopment. And I'm going to talk about that in just a moment. We need far more intervention programs so that when we assess the children, we have somewhere to send them. It's always a bit of a chicken and egg problem that we have here. And we need more systematic research to document the long-term outcomes following sepsis in low and middle income countries. The WHO has set guidelines for training rehabilitation personnel in low LMICs, and there are a number of resources for that. And today, though, what I'm going to do is focus specifically to give you an example of tool development that we're doing in the International Global Health Institute that I belong to. So one of the contributions I hope to make to improving care for children post-sepsis is I have experience developing tools in a number of areas. And in relation to sepsis, what I was asked to do by a colleague of mine, Dr. Mark Ansermino, was try to come up with a neurodevelopmental screening tool that we could use in a program that is operated in about 26 centers in Uganda called the Smart Discharges Program. He asked me to do this for good reason. There are no culturally appropriate, easy to use neurodevelopmental screening tools for children from birth to 5 years. And 5 years is the important part here. There are a number of tools that can be used for much younger children, but no single tool is useful for children up to school age. And making those available to frontline healthcare providers who may have limited neurodevelopmental training is also really important. So the objectives were to design and test the initial psychometric properties of the OptiDev e-screening tool. And we've designed this to be used from birth to 5 years, and it is a tablet-based tool. And the photo there is one of the nurses who's working on our data collection, doing an assessment of one of the youngsters in the program in the follow-up. We created the tool from 3 sources. The first one was from using the Malawi Developmental Assessment Tool. This, we had permission from Melissa Gladstone, who has spent years developing this tool. It is an excellent tool, and it has 136 items. It is culturally appropriate, and it is well used in a number of countries in rural Africa, and it can be used up to 6 years of age. The limitations for the purposes that we had were that it does require extensive training for those administering it. It takes a long time to administer, and it has specific props and equipment. And that makes it a little less portable and easy to roll out and quick to administer. We also took item information from the evidence-based milestone framework, and that allows us to use easier and more rapid identification for neurodevelopmental delays and deficits. And the final source was looking at the MBBCh, which is a comprehensive health screening tool used to collect data on household conditions as well as health outcomes. So we used these three already developed tools so that we weren't starting from scratch. And we took the items that were most relevant, that did not require the use of equipment, and that could be easily asked by a healthcare provider, a frontline person, to the families. So the tool is done through direct observation or parent report, and no equipment or props are needed. It covers gross motor, fine motor, social language, and adaptive skills. And I've just listed a couple of sample items that so you can get an idea of what we might do. So at 6 months, we might see if the infant can hold and shake an object. It doesn't have to be a rattle. And at 18 months, we ask about self-care, such as feeding skills. That also gives us an idea of their fine motor skills, if they can pick up food with their hands, and eye-hand coordination, because they can get it to their mouth. So we're trying to combine skills within a particular item to make this tool shorter. We've done initial psychometric testing in Uganda. We've had fantastic support with grants and personnel from the Institute for Global Health here in Vancouver. And I've been absolutely wonderfully fortunate to partner with another Liisa, who is an investigator at Harvard Center for AIDS Research and the Global Health Institute. And she's a pediatrician and has set up a prospective study looking at 600 mothers and infants related to biological factors associated with HIV. And we have tagged on to her study. And what we want to do is longitudinal follow-up of that cohort to 5 years. And we're administering the gold standard of infant development in Western countries. We did look at other options and came up with this as being the best that we could at the time. And we're using that to compare with the OptiDev, and we're starting the assessments at 3 months. And we've started our phase 1 study, testing 500 infants between 3 and 24 months. We're hoping to get up to 600 in the next 18 months to finish the 24-month follow-up. With the total data set, we will do a number of standard tool development analysis. We'll look at the internal consistency of the items. We'll look at the reliability. And we'll also look at how well the OptiDev compares to the Bailey scales. And today I can report on the latter of those, the concurrent validity, some preliminary analysis. So with the 500 subjects, we have tested up to 24 months. Our scale scores are significantly correlated with the 6 subtest scores of the Bailey. And in the full sample, the correlations are very high, and they are also very high when we split the sample between male and female children. And so I don't want to get too excited because we don't have the full sample yet up to 24 months, but I will say I'm cautiously optimistic that this will hold, and that we have a strong concurrent validity between the OptiDev and the Bailey scales in children from birth to 2 years, sorry. And our goals moving forward are to leverage these findings to generate grant funding for validating the tool in children from 24 months to 5 years. We are in fact waiting on a grant submission, hopefully any minute, to be able to continue this work. We want to integrate the tool into post-sepsis follow-up programs. And the one I know best is the Smart Discharges program that was developed here in Vancouver. We want to modify the OptiDev items for use in other countries, particularly around the language questions and some of the self-care activities. We want to develop simple early neurodevelopmental intervention materials to be able to provide to families. And finally, to work with our partners in hospitals and in government to expand neurodevelopmental treatment services for children, first in Uganda, and then expand to other countries. So I'm very privileged to be here today, but I represent a fantastic team who have been helping support the OptiDev work. My co-investigator, Dr. Mark Anselmino, co-investigators, Dr. Matthew Weens, Bella Wang, and Jeffrey Bone, and my collaborator, Liisa Bevel, and Dustin and Peter, who helped set up the data capture system, and Rose and Macaline, who are our fantastic nurses who do the data collection on the ground in Uganda. And I understand we'll be doing questions after. So thank you very much. And I will stop sharing and we can hear the next presentation.
Awesome, Dr. Holsti, thank you very much. And just as a reminder to folks, we do have a Q&A button at the bottom of your Zoom. Drop your questions in there. I've already seen a couple that are, I think, really interesting. So we'll turn over to Dr. Mark Mikkelsen. Thanks for joining us.
Thank you so much for having me. First, can somebody just let me know if you can see my screen?
We see your, it's changing. We now see your presenter view.
Okay. Let me see if I can move this one over. Take two.
No problem. There we go. We see just your whole slide.
Okay. So thank you again for the opportunity. And Liisa, thank you for giving us an overview of sepsis survivorship as it relates to children. In terms of disclosures, I'm a co-investigator of the National Institutes of Nursing Research iTransfer study. I'm also one of the founding members of something known as the Critical and Acute Illness Recovery Organization, or CAIRO. Also important to acknowledge that back in 2010, based on a family member who's now doing well, a neonatology sepsis survivor I began to work a lot on sepsis survivorship. And while I'm going to be speaking today about the lives of adult sepsis survivors, shout out to Liisa and others who continue to move us forward to understand the needs of pediatric sepsis survivors. So in terms of our learning objectives, I have three. One is going to be to share with you the long-term health consequences that are experienced by adult sepsis survivors. And then hopefully I'll give you some tips or strategies that can help us to more effectively educate sepsis survivors about their life after they are discharged, and also to highlight the opportunity to more effectively partner with our post-acute care providers to implement strategies that can enhance and improve sepsis survivors' lives. So in terms of making sure that we're all on the same page, so when I talk about sepsis, I'm talking about the body's dysregulated host response to an infection that's associated with a life-threatening acute or acute on chronic organ dysfunction. I'll speak to the dysregulation part shortly, but in terms of numbers, and to acknowledge that sepsis survivors can be survivors of viral illnesses or bacterial illnesses, in the magnitude, just focusing initially on the United States, but the reality is that at the global level, it's astounding. So while we should and do focus a lot of our care on the patients who arrive to the hospital and subsequently succumb, the reality is, and the good news is, that the vast majority of patients hospitalized with sepsis will survive. In excess of 1.4 million patients in the US alone. So that sets the stage for what are the long-term consequences of sepsis. So I'll cover some of these, not all of these in the similar amount of depth, but from a head-to-toe perspective, there's neuropsychological impairment. That would include cognitive impairment, as well as those patients who experience anxiety, depression, or PTSD. There is acknowledged overlap between post-intensive care syndrome and sepsis survivorship, but an important distinction is that about half of all patients that are hospitalized with sepsis will not need to be cared for in an ICU. And yet we've learned that many of these consequences impact sepsis survivors, irregardless of whether they ended up in the ICU. There is physical impairment. There is inflammation that is associated with cardiovascular risk. That's a topic that I'm not going to spend as much time speaking about today. And then there's this concept of sepsis-induced immunosuppression. It begins during the hospitalization, but just as a heads up, it clearly relates to the rehospitalization risk that sepsis survivors incur. That relates to healthcare resource use, and we'll speak about the 30 and 90-day readmission rates, which are quite staggering. There's also an association when we think about the amount of impairment and the subsequent health-related quality of life, and there's clearly an increased risk of mortality for these patients. So I'd alluded to this idea of the dysregulated host response, an important work by Sasha and Yendi now a couple of years ago. What they found was amongst sepsis survivors, a number of them, nearly 2/3, sustained ongoing inflammation. And when they looked at a biomarker that's associated with immunosuppression, they see a decrease or an increase in the risk of subsequent infection. And these both hyperinflammatory as well as immunosuppressant findings were associated with a higher readmission rate of 1 year. And I think that's important context when we think about cognitive impairment and physical impairment that survivors experience. So this was work done by an old friend and colleague, Jack Iwashina, in 2010. So now it's 13 years old, but it's an important landmark study. Jack and colleagues studied the health and retirement survey. So what they're looking at is elderly sepsis survivors, and they took advantage of this longitudinal study that tracked both cognitive and physical impairment, both before sepsis and then after sepsis. And what we see here is a clear step up in the wrong direction of significant cognitive impairment. So prior to sepsis, these patients had cognitive impairment that would align with mild Alzheimer's at the rate of 6%. And after sepsis, that number increases to 17%. Over the last decade, work has been conducted. It's also occurred in the pandemic environment, meaning looking at what is going on that leads from an infection, either bacterial or virus, that can lead to cognitive impairment. And one of the things that has been discovered is this idea of brain scavenger cells or microglia that when turned on can continue even after sepsis or the bacterial infection has resolved, that appears to be related to cognitive impairment. But that increase from say 6 to 17%, an absolute increase of 11% in those patients who were studied, is important information to be aware of. And subsequently, in a couple of slides, I'll speak to this idea of how do we screen patients for cognitive impairment and give some practical tips there. In addition to cognitive impairment, there's also worsening in terms of functional impairment after sepsis. What this figure depicts is that no matter who the patient was before, whether they had no functional limitations, mild to moderate functional limitations prior to sepsis, or already had severe physical functional limitations, they were significantly worse after they experienced sepsis. We also understand that functional impairment in general is associated with hospital readmission, mediated in part through frailty. And we also, specific to sepsis survivors, and when we think about the use of post-acute care in work that now also is nearly a decade old, but an opportunity for improvement that still exists, is that in the study by Chow and colleagues, post-discharge acute rehabilitation was associated with reduced long-term mortality among sepsis survivors. Let's remember that when we talk about what proportion of United States sepsis survivors go to acute rehabilitation, foreshadowing not enough. I had mentioned long-term mortality. What this study, also by Sachin Yendi and colleagues, demonstrated is that there does appear to be a relationship between your illness severity, meaning patients who develop an infection that requires an ICU stay. There is an association between the degree of your sepsis and long-term mortality, meaning that patients who are hospitalized with sepsis compared to those who are hospitalized for a different reason have increased long-term mortality, and it's highest amongst those that do require ICU level of care. I think that's an important acknowledgement for all of us in healthcare to be aware of. I too, like David, am an ICU physician, and yet when I discharge a patient to the floor, an important question within our hospitals is, what does my colleague who's admitting this patient now to the floor and is about to discharge them, what are they communicating about life after sepsis? The reality is not enough, but it's conversations like this and opportunities provided like this that will increase the frequency with which we effectively educate and prepare patients for hospital discharge. I had alluded to the fact of 30-day readmission rates. It was around 2012 when investigators began to study the rate of 30-day hospital readmission. It was totally under recognized how commonly these patients are being readmitted. This is important because if you're not doing this at your local hospital, you're missing a large proportion, i.e. a driver of your hospital readmissions. So the rate is somewhere between 20 and 25% of all patients who survive sepsis will be rehospitalized within 30 days. By 90 days, that's somewhere between 40 and 45%. CMS recognized this, and if we look, the columns here talk about the number of index admissions, number of all-cause readmissions, and what we see here is that they're ranked from 1 to 10 in terms of the frequency with which they're being rehospitalized. But given how common sepsis is as a reason for hospitalization, it's a huge driver in terms of who is readmitted to the hospital. Because I probably won't mention this again, just to ask all of us, when a patient presents to the hospital, a question that we should be asking and we should be looking into is to look backwards in the chart and look to see if were they actually recently hospitalized with sepsis. It's a circular situation where many patients who are presenting, we are slow to recognize that they were recently hospitalized, potentially with another infection, and it should impact our care, meaning we should have a higher index of suspicion that they have another infection, and we need to be aware of their prior antibiotic use. So why are these patients being rehospitalized? Well, in nearly 7 out of 10 rehospitalizations, we initially found this in a cohort at Penn. It's infection that brings patients back. So 69% of patients for unplanned readmissions was directly related or indirectly related to an infection, meaning a patient came in because they had a fall and they were found to have a urinary tract infection as an indirect potential situation. About half of these cases are a readmission related to an infection that is either new or recurrent, or alternatively, about half of the time it could be viewed, half the time it's new and half of the time it's either recurrent or unresolved. So an example of a recurrent or unresolved infection would be a patient who was hospitalized with pneumonia, could be a different organism, and then is rehospitalized again with a pneumonia. An example of a patient who's readmitted for a new infection would be your initial hospitalization was for pneumonia and your rehospitalization, for example, was for a C. diff infection. What we found was confirmed in work out of the University of Michigan by colleagues there. So we may ask, why is it? What's occurring? Well, the reality is that at the cellular level, there appears to be a number of different mechanisms by which this occurs. Cellular apoptosis that could increase the risk for a subsequent viral infection. And ongoing work is needed, but we're beginning to better understand that there's a combination of dysbiosis, meaning if we give antibiotics, dysbiosis increases the risk for a subsequent infection. And then there's also cellular changes occurring in terms of immunosuppression. The take-home message for clinicians is that patients for a period of time between 30 to 90 days are at significantly increased risk of developing another infection. And not enough of our patients know that information. There's this concept of ambulatory care sensitive conditions, which I think is important for us to think about when we think about better partnering with post-acute care teammates. And the big three reasons for why patients are rehospitalized are: one, infection or recurrent sepsis, which we've already spoken about. There's also this concept of fluid balance, not enough or too much, that can lead to renal failure through dehydration or volume overload for patients with pre-existing conditions. And then potentially or partly mediated through weakness, there's an increased risk of aspiration pneumonia. There's also worsening in terms of patients' COPD. At least it is thought that potentially that's related to the ongoing inflammation that the body is experiencing after sepsis. So to wrap it all together, before we talk about how can we more effectively educate and prepare survivors, is that health is known now to be compromised after sepsis. Surviving sepsis does not end the time that your antibiotics stop or prior to hospital discharge. Readmissions are common, and that new or recurrent infection is often the reason. In general, at present, coordination of care is lacking, and therefore opportunities to focus on this are needed at many, if not all, of our hospitals. And information is available. For those that may not know, there's, if you type in Life After Sepsis YouTube, you'll find the SCCM and Sepsis Alliance video that summarizes a lot of this information. It is a useful tool for use to provide to your patients at your hospitals. So while this sort of schematic or figure we originally created for critical illness survivors, it largely can be applied to sepsis survivors. So how do we move forward? One, we need to increase awareness of the idea of sepsis survivorship, educate patients and caregivers, identify and rehabilitate the physical and neuropsychological impairment that will afflict many patients, that the effective need to rehabilitate and be aware in partnership with OTPT colleagues about who would best benefit from acute rehabilitation, and then care coordination. So where do our sepsis survivors go? This was work by Jessica Lee and colleagues that I participated in. This is amongst CMS beneficiaries. Where do patients go after sepsis? What we see is that many of them, in an increasing number of patients, despite these recognized or now recognized impairments, will go home. 46% as of 2016. As of 2016, only 46% of patients were receiving some type of post-acute care, but that's still about half. Infrequently, patients went to home health. Interestingly, for those in this space, about 20% of patients are recommended to receive home health. Unfortunately, many of them will decline that offer, which leads to that 13% or so number. Many patients, because of both their chronic conditions as well as the worsening of their state, their worsening physical function, will require a skilled nursing facility. And IRF is acute rehabilitation, and that is unfortunate that that is such a low number, but that is the reality. And then some patients will require, who develop chronic critical illness, will require an LTAC. So a couple of strategies to be aware of. Partha Deb and Kathy Bowles and colleagues published an important study. They used an instrumental variable analysis to come up with a quasi-experimental study design that looked at, of those patients who received or were discharged to home health, if they were seen frequently in the week after sepsis at home, and most importantly, and they also were seen by a provider in the outpatient setting, they had a dramatic decrease by 7% of the rate of needing to be rehospitalized. So why might this be the case? Well, it's this general idea of saying that frequent visits to home among those who are discharged home, or a concept sort of hovering and then quickly identifying an ambulatory care sensitive condition and then being able to be evaluated by a provider in the office is best care. That's something important that Kathy and colleagues are studying as part of iTransfer. And I'm here today to sort of share that message that says frequent hovering for those patients that are discharged to home with home health services, when coupled with early provider follow-up, is beneficial to our patients. An important thing for us all to be aware of is currently there is no ICD-10 code for post-sepsis condition. However, there is good news coming. Why is this so important? Well, among 165,000 sepsis survivors who were discharged to home health, less than 10% of them were actually recognized to be sepsis survivors. They were more likely to be recognized as potentially someone who recently had a pneumonia, but that likely does not help to understand the risks that those patients would subsequently incur. And so calling sepsis survivorship what it is incredibly important. So if sepsis survivors are invisible, then it begs the question of how can we more effectively identify these patients, rehabilitate them, and prevent these adverse health-related events. So earlier this year, on behalf of a number of colleagues, I had the chance to present a proposal to the ICD-10 CM committee, and many organizations, including the American Thoracic Society, SCCM, American College of Chest Physicians, and the American College of Nursing, supported this proposal. The goals were to increase awareness by creating a sepsis aftercare code. And the good news is that this will go live October 1st, 2024. The goal will be to make more visible those patients who have experienced sepsis to our post-acute care providers, as well as to outpatient providers. The other benefits are outlined there, and this does align with Surviving Sepsis campaign guidelines to more effectively identify and then subsequently rehabilitate sepsis survivors. A couple of practical tips to improve identification of sepsis survivors in advance of October 1st, but also to complement that sepsis aftercare code, is that at the hospital level and the post-acute care level, if we look at the hospital discharge summary, clearly if it says sepsis, that's awesome, but that's often not the case, having looked at a bunch of charts. And so we should also recognize that often we as clinicians view sepsis as being resolved. So if we look to see, was a patient hospitalized with a specific infection, and the most common ones are listed there, it's reasonable to assume that that was a sepsis survivor if they were hospitalized. In addition, if a patient is being discharged to antibiotics for treatment of an infection, as opposed to suppressive antibiotics for certain patient populations, that's also a useful strategy to say, oh, that's a sepsis survivor, and then subsequently ensure that they receive the care coordination that they often need. For those that are wondering, how could I effectively screen for an impairment? As part of the SCCM's International Conference on Prediction and Identification of Long-Term Impairments After Critical Illness, be it cognition, anxiety, depression, PTSD, or physical function, there are recommendations from that body of work that can be applied to sepsis survivors. And if people are interested, I'm happy to share any of the slides that are being shown today. The next couple of slides I'm going to go over briefly, but a shout out to my old Penn colleagues who put together some amazing work. So this is an example of a post-acute care sepsis aftercare pathway. So for those inpatient providers, you may say, well, that looks an awful lot like SEP1. And the reality is it does, because the same idea would apply to a patient, for example, in a skilled nursing facility. Thinking about it from an ambulatory care sensitive condition. For example, if you screen patients twice daily for a new fever, if you're cognizant and looking for a new problem, often being a new or recurrent infection, then the ability to stamp that out early is clearly evidence-based and can be applied in the skilled nursing facility environment. This was work in concert with the Healthcare and Hospital Association of Pennsylvania that we had done both locally at Penn Medicine, but we also partnered to roll this out across the state of Pennsylvania, where we designed standard education for sepsis survivors that took into account the frequency with which these patients were being rehospitalized, encouraging patients, their loved ones, as well as post-acute care providers to be checking temperatures and to look for signs or symptoms that might suggest a new problem. Again, often that new problem, its name was an infection. There's also opportunity to learn from other home health services that have designed their program to meet the needs of sepsis survivors, recognizing the frequency with which they have challenges either with swallowing or weakness or cognition, by embedding within your program physical therapy, occupational therapy, speech and language pathology, rehabilitation. All of this shows at least a strategy to meet the needs of sepsis survivors. And so if there's any sepsis coordinators on this call, a comprehensive care model begins with hospital admission, focuses clearly on SEP1, that 3 and 6 hour sepsis bundle. But sort of the new frontier is going to be ensuring that patients receive the education that they need, that they are aware and looking for signs or symptoms of a new infection, and then ensuring that patients receive early follow-up. That 7 days, it's been a goal for a while in medicine in general, but it's clearly beneficial to sepsis survivors given their risks. So with that, I just wanted to say thank you both to my prior colleagues at Penn Medicine, where I was for 20 years, and my amazing colleagues here at UC Health. Again, for those looking for more information or another tool, that Life After Sepsis video, the link is there. And otherwise, I'll just say thank you again for the chance to speak at this forum, and happy, along with Liisa, to take any questions that you have.
Awesome. Thanks so much, Mark and Liisa. I really appreciate both of you presenting. This is such a nascent field, right? There's so many questions. As a moderator, I've been sorting through questions along with our team, and there's so many. I guess I'm going to start with a couple things. One of the questions, I think, Liisa, you might have answered briefly in the answers of the questions, but I had it also, and I haven't had time to delve in and see your written answer. When you're modifying assessment tools such as the OptiDev, how do you make sure it's culturally appropriate and appropriate for the community you're using it with? Do you have subject matter experts, I guess maybe I should say cultural experts in the community that you vet it with, or is there another methodology?
Yeah, we do. And I should be clear that the OptiDev hasn't been used in other countries other than Uganda at the moment. That's all. We got to make sure this works first. So we're starting in a place where we have had lots of work done with the Institute for Global Health from Vancouver. And so what we do is work with our partners on the ground and make sure that the language, the kind of tasks we would ask the children to do, or the types of things we would ask families to report on, are typical tasks. And so we have folks we can go to help us out with that. And of course, if we then went into another country, we would start over. We have other work in South Africa and other countries. We would do exactly the same thing. So it doesn't change the underlying items that we're getting at. It just changes the language that we use or the slight description of what we do. So it's not a huge rewrite. It's just a matter of making sure that it will work and that families will understand what we're asking.
Got it. And then thinking about post-acute care pathways and screening tools. Mark, you showed a slide with a bunch of different domains and tools for those different domains, things in the pulmonary function lab with a 6-minute walk test and cognitive assessments. Is there a way to boil that down? And maybe this is for both of you, maybe Mark first and then Liisa. Is there a way to boil that down to something that's sort of an even simpler screening tool that even a family member could give at home?
Oh, actually, that's a really cool question. So let me think through the different domains. So cognition, I would say the MOCA does provide or does require a level of sophistication. That being said, though, having done lots of talks like this over the years, it is so common where people talk about blurry thinking, fuzzy thinking. It actually reminds me I did not include the slide, I think it's in the appendix, but Hallie Prescott, Derek Angus had a JAMA review about sepsis survivorship, and there's this cool picture of like, are you having difficulty concentrating? Do you feel weaker than normal? I think those are actually really good prompts that family members can and should ask. The reality is most patients, if any of you have had loved ones who have been hospitalized with sepsis, the fuzzy thinking is super common. The nightmares, especially if they've been ventilated, are very common. People just don't ask enough. And then the big one is just weakness, and people know that and they feel it. But then the question is, are we both identifying it, and then are we engaging the right people to get them the rehabilitation? And I would say no. The reality is I don't think we really are. A lot of patients end up in a skilled nursing facility, but I'm still blown away that it's only 2.5% of all sepsis survivors can get in the door of acute rehabilitation. I didn't mention it, but it's because of the Big 13. It's a policy issue, meaning that it's things like stroke that have been identified as the clear needs for acute rehabilitation. And there's this sort of backwards logic that says that if you're in acute rehabilitation facility, that you have to provide X percentage. I think it's around 70% of your patients need to be one of those Big 13, and sepsis is not one of them.
Wow, that's really interesting. Yeah, mind blown again. Liisa, are there opportunities to adapt some of these scoring things you're using for kids to adults, or is there a similar sort of pathway for?
So I'm gonna stay way out of adults because that's what I know anything about, other than being one myself. But for kids, so yes, I think there are ways that we can educate families about thinking about what kinds of questions they can be asking. I was just in a meeting yesterday, and there's actually a new information package, which I will put in the chat when I finish talking, for families about sepsis, and it includes how to get referrals to various services in British Columbia, but it shows the in-hospital algorithm and Anyway, it's a very detailed document, but I will put it in the chat in a minute. The reason I hesitate is that when I started working in neonatology, we knew a little bit about follow-up, but what really drove clinical care was getting very systematic, well-controlled, detailed outputs following extreme prematurity. And sepsis was one of the categories of children who we followed in Vancouver for sure. There were specific criteria for that. And it really took getting a group of people from across Canada together to agree on ways of providing follow-up for the care of these children who hadn't been saved before, essentially. And the benefit of that is we now know how to treat them better, both in hospital, but also out of hospital. We had the data, we were able to lobby families who don't appear to be the political I'm looked at as a person who would have a bias if I go to the government because I want funding for OT. But if a family does it, then they're a voter, despite the fact that I'm a voter. So it gave us information so that families could be used to help us advocate. We got together to advocate for better services. It's still not perfect, but it's at least better. So on the one hand, yes, I think there are things you can do at home. On the other hand, what I would actually really love to see are national standards for pediatric follow-up. And it does take a while to get all of that sorted out. And you're never going to get 100% a perfect kind of follow-up, but you can get something that's good enough to get us detailed information. And, it's interesting to me that 90 days is considered, we're struggling to get people to see them at 90 days. Long COVID ain't going away, folks. And we know from the adults that it's hanging around for a long time. And I would postulate that that's going to be true for kids as well. And so if we're willing to invest in the front end, we need to be willing to invest in the back end.
Thank you. No, that makes a lot of sense. And I guess that makes me wonder, is there a role for, sort of people that are publishing best practices, Surviving Sepsis campaign? It always sort of started with the more, I don't know if I want to say sexy side of sepsis, but the initial resuscitation scrum of sepsis, and sort of left people by the wayside, hey, great job, you lived. But I wonder, and looking at a couple comments, one in particular from Susan Korstad in the chat, where she wasn't even told she had sepsis. Like you mentioned, Mark, it's not often in discharge summaries because the people caring for the sepsis are in the ICU and the people discharging the patient weren't there at the time. Do you think we should be turning our attention to those guideline writers and committees on making best recommendations for best practice in the 3 months after sepsis?
Totally. It's a great question. So I'll call it a work group. I think that's correct. There was a work group in the most recent Surviving Sepsis campaign guidelines that began to acknowledge long-term outcomes. Those original recommendations largely, if you just look at it and about post-intensive care syndrome, you'll see a lot of overlap there. I think the missing piece is that it does not highlight specific for sepsis this risk of new or recurrent infection. Mm-hmm. And therefore, that's a big opportunity. And I would say, knowing the folks who are involved in that, that'll be in the future. One, because yes, there is cognitive impairment. Yes, there is physical impairment. Those are super important to patients and families. But what brings people back into the hospital is that infection. And that's an important message. And because the guidelines are so powerful, we're missing the mark. So if anybody, including Laura, is on the call, who is heavily involved in Surviving Sepsis, key great opportunity to sort of spread the word in terms of that important message.
Yeah, thanks. And Liisa, do you have thoughts?
No, not on that one. Thanks.
Okay. Yeah, of course. Yeah, and I'll lobby Laura Evans, my colleague and mentor, also, because I think there's a misconception that there's not much science about outcomes after critical illness or outcomes after sepsis, and I think the two of you have dispelled that myth. There's a lot of science. We just need to turn the spotlight towards it. One final question, and this is, I think, a great practical question, which is, other than early follow-up with a primary care provider, do either of you know of facilities that have programs that follow sepsis patients more closely after discharge, who are sort of implementing these best practices?
Go ahead, Liisa.
Yeah, I can just say from the pediatric perspective in BC, I wouldn't say it's sepsis specific. I think that it's any child who is seen as having a reason for high risk for neurodevelopmental issues can get referred to the community, and parents can do the referrals themselves. They don't need a pediatrician to get a referral. And we've put that information in the booklet that, thank you, Stephanie, has put the link in for that information to empower parents to be able to do that.
Got it. Awesome. Well, thank you both again. I learned a ton. I've always had a little bit of more curiosity than time about this subject, and I really appreciate it just on a personal level. And I think based on all the number of questions and comments, it was very informative for many people. So thanks again for spending some time with us.
Thank you. My pleasure.
Awesome. I can't believe our day is almost over, team. As we head towards our final panel discussion, do check out the comments, some great thoughtful comments and a lot of wisdom. There's a link to the Action on Sepsis discharge tool by Health Quality of BC Canada. That again is usually there. I've not seen this particular document. They are often, I hate to use a Canadian stereotype, but just so reasonable. And so thank you for working on those projects. I'm going to introduce our next moderator, who will then introduce our panel. And believe it or not, I never thought I would see a day when we saw a panel discussion on preventing sepsis. You know, the Pacific Northwest Sepsis Conference, when we were thinking about our mission and vision, and I think for Sepsis Forum, it's the same. It's imagining a world without sepsis. That's simple. And I didn't ever think in my lifetime we would see that, but maybe it's actually more possible than I think. So let me introduce, and Dr. Kissoon, if you could turn on your video if you're able. Let me introduce our next moderator. Sorry, I'm just changing a few things on my settings here. I didn't know that a very worldly, thoughtful, collaborative pediatrician would be one of my heroes in sepsis until a couple of years ago. And then that's when I met Tex Kissoon. Dr. Kissoon is the president of Global Sepsis Alliance, co-chair of the Pediatric Surviving Sepsis Campaign, vice president of the Canadian Sepsis Foundation, advisory board of the U.S. Sepsis Alliance and the African Sepsis Alliance, and co-chair of World Sepsis Day, International Pediatric Sepsis Initiative, Pediatric Surviving Sepsis Campaign Guidelines Committee co-chair, I think. As you can tell, he is passionate about children and women's global health, and is really, honestly, truly world-renowned for his global leadership in working with sepsis, collaborating with the World Health Organization. And so Tex, it's wonderful to see you, as always, in front of a beautiful tree, which is where I expect to find you. And every year I see you, you look younger. So someday you'll have to teach us that secret. But I'll let you go ahead and introduce our panelists. I'm going to put their photo up while you introduce.
Hey, thank you very much for this generous introduction, David. And I'd like to thank the coordinators and those who have been involved in preparing and getting us working together on this wonderful sort of program. I know the last time we were together in the same room, and I hope in the future we will be together in the same room. And the whole idea is this cross-border coordination and cross-border collaboration. I think it serves us very well. I will be chairing the session, and in addition, I will be giving one of the talks, and I will sort of introduce myself at the time, and obviously with great lavish praise. In the meantime, I'd like to introduce two of my colleagues, well, one at a time, I guess, who have been instrumental in the fight and prevention of sepsis. Many of you know, in BC here may know Manish Sadarangani. Manish is the director of the Vaccine Evaluation Center at BC Children's Hospital Research Institute, and is an associate professor in the Division of Infectious Disease, University of British Columbia, Department of Pediatrics. However, Manish's reach has been global. He has worked across the world in many places, including Sub-Saharan Africa, Asia, Australia, North America, and Europe. His research links clinical skills with basic microbiology, immunology, epidemiology to address clinical relevant problems related to immunization and vaccine preventable diseases. I can tell you that Manish is my resource whenever I have had a question relating to vaccines, and especially in the last few years, when do I take the COVID, which COVID vaccine do I take, et cetera, et cetera. He has been very, very helpful in that way. And something that you may not know about Manish, I think he has great taste. He plays soccer, and of all the sports teams he could have joined, he chose to join a Caribbean soccer team, despite not being from the Caribbean. And I appreciate that. So with that, I'll turn the floor over to Manish, and he will be speaking to us on the role of vaccines and immunization policy in reducing the burden of sepsis through prevention. Manish.
Thanks, Tex. Before I get into my slides, you may be disappointed to know that the last truly Caribbean player left our team in the last 12 months. And so we had to rebrand because we felt it was not justified to have a Caribbean name without a Caribbean person there. But we'd already printed all our jerseys with the CAS logo. And so we rebranded as Club Cascadia. So anyway, that's an aside. So I'm just going to pop up my screen here, and then hopefully you can all see my slides. If not, then somebody just let me know. So I was asked in this session around preventing sepsis to talk about the role of vaccines and immunization policy. And I want to thank Tex and the organizers for the invitation to speak to you about this today. So I just want to acknowledge that I'm at BC Children's Hospital and on the traditional, ancestral and unceded territory of the Coast Salish peoples, including the Musqueam, Squamish and Tsleil-Waututh nations, and very grateful to be able to live here and work here and play soccer here. Okay. All right, and my disclosure, so I have some salary awards from the Hospital Foundation here and the Michael Smith Foundation, and I've had projects funded by a number of vaccine manufacturers, but all the funds have gone to my institute and I've not received any personal payments. So the objectives that we'd agreed I would talk about today was recognizing the historical and current role of vaccines in the prevention of sepsis, appreciate how immunization policy can contribute to reducing sepsis, and then thinking a little bit about future challenges and opportunities for vaccines in sepsis prevention. And these are clearly quite broad topics. And so as I go through, I'm going to use some specific diseases and specific pathogens and vaccines as examples in these different areas. So I'm not going to be able to cover everything. And if I haven't covered your favorite vaccine or your favorite disease or your favorite population, then I apologize in advance for that. So starting with the historical and current role of vaccines in prevention of sepsis, and I'm going to use examples around meningococcal vaccines. And sort of for me, this is something I'm very passionate about. So I trained most of my life in the UK, and meningococcal sepsis was one of the sort of most devastating, most common forms of sepsis that we would see in pediatrics, and something that is very, very dear to me. So I thought I'd start by showing you this. Many of you will have probably seen from this study published a few years ago in The Lancet, the evolution of sepsis-related deaths globally. And this shows the changes from 1990 to 2007 and then to 2017. And I just want to highlight 4 specific areas here where there has been significant reductions in sepsis-related deaths over these decades. So despite still being 1 and 2, lower respiratory tract infections and diarrheal diseases have seen, 30 to 40% reductions in both of these time periods from 90 to 2007, and then from 2007 to 2017, you can see in this last box here. Going down, meningitis has dropped from number 10 to number 15 on this list. And again, in each of these time periods, seen around a 30% reduction in terms of the mortality from sepsis. And then down at the bottom here, typhoid and paratyphoid, that I'm not going to talk too much about, but has also dropped from sort of 15 down to 20 and has seen massive reductions. And a large part of this is due to vaccines. So I want to start off by talking about meningitis and specifically meningococcal meningitis. And I want to talk a little bit about the meningitis belt in Africa. So I'll explain what the colors mean in a future slide, but for now I just want to talk to you about this part of sub-Saharan Africa with extremely high rates of meningitis. So we're talking at a baseline of 10 to 100 per 100,000 people. And in epidemics, you're getting up to 1,000 per 100,000 population. So 1 in 1,000 people getting meningitis, a very devastating disease, often associated or as part of a sepsis syndrome. And just to contextualize that a little bit, in outbreaks in Canada, we're still talking about an incidence of less than 2 per 100,000. So I think a lot of people, it's difficult to appreciate how many people this is with this devastating disease. And before 2010, essentially there was, relatively low quality surveillance, but surveillance nevertheless. And when there was a decision that the epidemic threshold had been reached, then there was a reactive campaign using a polysaccharide, so a relatively poorly immunogenic vaccine. But that's a lot of people will have to die before you get to that point. And so this collaboration was led by the WHO, PATH, and Gavi, called the Meningitis Vaccine Project. Really the first of its kind. And we talk now about, through COVID, about these government, public, private partnerships and academia and industry working together. But at the time, this was truly sort of almost unthought of innovation. And essentially, it was working backwards. So the governments, this collaboration asked the governments of these countries how much they could afford for a vaccine, for a routine immunization program. And they came back with the consensus that it had to be less than $1 a dose. And again, just to put that into context, something like a pneumococcal conjugate vaccine using similar technology currently in North America would cost $100 to $150 per dose. So this is extremely inexpensive, and off the face of it, you would think is unreasonable. But nevertheless, the consortium aimed to develop a highly effective, low-cost MenA vaccine, and this was the serogroup or the type of Neisseria meningitidis that was responsible for most of these epidemics that could be effectively delivered in these very low resource settings. So essentially, you're looking for one dose product, and also development of surveillance systems to monitor the impact of this vaccine. And so to cut a long story short, the vaccine was licensed in 2009 and then rolled out across the meningitis belt. And the early adopters were in yellow here in 2010. And then you can see over a period of 6 to 7 years, it was adopted throughout this meningitis belt. And close to 100% of 1 to 29-year-olds were vaccinated. Extremely effective campaigns. Pre-immunization, the rate in the years just prior to these campaigns was around 60 per 100,000 in terms of meningitis, and afterwards decreasing by 60%. So not 100%, but 60% in a real-world setting. Decreases also seen in individuals who are not part of the campaign, so the younger infants and the older adults as part of a herd immunity, and mortality decreasing by 64%. And this was one of the earlier publications and one of the first to demonstrate this very, very rapid impact. So to me, this is an incredibly huge success story of preventing meningitis and preventing sepsis. But, we can't sit still. The goalposts shift. And, one of the reasons I like infectious diseases is because you're having to constantly battle these evolving pathogens. And so you can see here, this is showing the proportion of meningococcal disease in this part of Africa caused by different serogroups. This is looking at the proportion of the outbreaks. And you can see that pre-2010, before this vaccine was available, most of the outbreaks are being caused by serogroup A. But as you introduce this vaccine, although the overall rates were much lower, that you're then seeing other serogroups emerge as significant causes of meningitis. And so serogroup C here in the green, and there's been some recent outbreaks of those, serogroup X, which we really only see in sub-Saharan Africa, and serogroup W, which is it's a global issue. And so for the future, and this was recently published in the New England Journal just a few weeks ago, there has been development for an almost equivalently low-cost vaccine, which is just targeting the MenA, but also the C, W, X, and Y for sub-Saharan Africa. And so this is a trial. This is some data from this randomized control trial done in Mali and the Gambia, where children and young adults were randomized to either receive this pentavalent vaccine, so including all of these serogroups, against a quadrivalent vaccine. So this is one of the vaccines that's commonly used in Canada and in the US, and looking at the immunologic response And essentially, you can see that for the 4 shared serogroups, that this vaccine, which is also produced in the low-cost setting, so is aiming to be equivalently low cost, was superior. And then subgroup X is not in this vaccine, so as expected, this would be superior. And you can see that in the sort of teal color here, that most of the vaccinated individuals were achieving almost 100% of them were achieving protective levels of antibody against almost all of the serogroups. And so the conclusion from this study was that in this age group, in countries in Mali and the Gambia, that this vaccine was at least as good as the licensed vaccine that is being used in North America. And this vaccine is likely to be implemented in the near future. And, there was reference by David about prevention of sepsis, and this is really part of a very ambitious goal that has been laid out by the WHO, and there's a roadmap here that anyone can go and download called Defeating Meningitis by 2030. And it's vaccines like this and others that are going to be part of that campaign. So moving on to talk a little bit about immunization policy to reduce sepsis. So some of you may be aware, some of you may not, but the WHO have a recommendation of vaccines that they expect all countries in the world to adopt and to include in their routine immunization schedule. And in most of the world, this is referred to as the EPI, or the Expanded Program on Immunization, and currently includes 12 different antigens. And just to pick out some of these here that are sort of mostly relevant to sepsis particularly, but I would say, there was some comments made earlier in this meeting around how the final common pathway for a lot of viral infections is sepsis, and for a lot of these things is sepsis. So if you can prevent the original infection, then you can also prevent and reduce sepsis. So, you could argue that all of these have a role to play. So BCG against tuberculosis, hepatitis B, polio, these DTP, so diphtheria, tetanus, pertussis containing vaccines, Haemophilus influenza type B, preventing bacteremia, meningitis, epiglottitis, pneumococcal conjugate vaccine, rotavirus to prevent diarrhea, measles, rubella, and HPV vaccine against cervical cancer. So these are the guidance from the WHO that, policy-wise, all countries should have all of these vaccines in their policy as a bare minimum. Okay, so going back to this table that I showed you earlier, I'm now going to go up here and talk a little bit about vaccines focusing on lower respiratory tract infections and diarrheal diseases as relating to those policies. So pneumococcal conjugate vaccine, this is one on that list from the WHO. So this is the current status, and it's taken a long time. These vaccines have been available for, the best part of 20 years now, and it's taken a long time to get to this point. So, as we saw with COVID, and as we see over and over again, the rollout globally is not done equitably, but we've got to a reasonably good point where 168 countries have introduced this vaccine, and another 16 shown in the yellow are planning. As you can see, again, the geographical distribution of those is not equal, and 10 that have not introduced these vaccines. And this is, one, I was trying to find some data to show the sort of overall effect at a global scale. There's an incredibly huge number of studies at a country level. So for almost every country that's introduced pneumococcal conjugate vaccine that has surveillance, there's a study that shows the impact, the positive impact. But this is sort of looking globally. This was published a few years ago now, showing that over time, one, we've reduced the proportion of children not immunized. So that's good. And you can also see that's been associated with a reduction in deaths from pneumococcal disease, which will be pneumonia, bacteremia, meningitis predominantly. So then going on to diarrheal diseases and rotavirus vaccines. So the rollout for this has been even slower and is not currently as widely used as we would like it to be. So 123 countries have introduced rotavirus vaccine, with another 16 planning to introduce it, and 55 that have not introduced, and as far as we know, are not planning to introduce this. And rotavirus has been the sort of single biggest cause of severe diarrhea and gastroenteritis across the world globally in young children. And this is some data from the Global Rotavirus Surveillance Network. So I'll start on the right-hand side first, showing between 2008 and 2016. So this graph here shows the percentage of children with gastroenteritis that have a positive test for rotavirus. And this is a good indicator of the burden of disease in communities. And you can see in countries where the vaccine has not been introduced, there's basically no change over this time period. On the left-hand side, this shows sort of a pre-vaccine period. here up to year 0 in various countries that are used as part of this surveillance network. And then in the darker pink, what happens after vaccine is introduced. And you can see again in the pre-vaccine period, similar to those countries that haven't introduced vaccine, there's not really any change, and there's reduction. Over time, you get fewer and fewer sites that are sort of many years out. As I said, the rollout is slow. That the numbers have gone down. So again, sort of highlighting the impact of a policy to reduce disease and sepsis. So what next? So this was a study from last year published in The Lancet, looking at global mortality associated with 33 bacterial pathogens in 2019. And a lot of these studies that I've been showing are part of this bigger global burden of disease consortium. And so number 1 here is Staph aureus, and then you've got E. coli, strep pneumo, which we've talked a little bit about, Klebsiella, Pseudomonas, Acinetobacter, Enterobacter, and those last 4, and even all of these actually to some extent, but particularly the last 4 are really highly associated with antimicrobial resistance. Would be Streptococcus, a major pathogen, particularly for neonatal sepsis, and then Enterococcus, Salmonella, Group A Streptococcus, which we've already also heard about today. So just bear some of those pathogens in mind, and as we go forward, the next few slides. So when we think about, so the future challenges are these pathogens essentially. Currently, these are the really big killers that we see globally when we try and look at the burden of disease. So where are there opportunities for vaccines? So I'm going to talk a little bit about vaccines against antimicrobial resistant pathogens. And right now there's a big move, there's sort of a big group at the World Health Organization working broadly in the area of antimicrobial resistance, and I'm part of a technical advisory group to the WHO specifically looking at what role vaccines have to play in reducing antibiotic use and also preventing antimicrobial resistance. And this is one of the documents that have been produced by the WHO, and there's going to be a few more reports coming out in the next sort of 12 months or so. But essentially, part of the various approaches here is, in the top left, investing in new medicines, diagnostic tools, vaccines, and other interventions. And so this is part of a multi-pronged strategy to reduce antimicrobial resistance and reduce antibiotic use. And so how does that work? So it works in a number of different ways. So clearly, if you vaccinate individuals, then you will directly prevent those individuals from getting sick against your pathogen of interest. And clearly, a vaccine against something like E. coli or Klebsiella is not only going to prevent the resistant strains, it's also going to prevent the susceptible strains. So you have a broader impact on sepsis that includes the resistance. You prevent complications. So for some pathogens where you get a lot of the burden of sepsis is in the secondary infections. So if you prevent the primary infection, you prevent the secondary infection as well. And then if you can reduce transmission, so we've seen particularly with the conjugate vaccines against Haemophilus influenza, Streptococcus pneumoniae, and Neisseria meningitidis, they have an incredible herd immunity effect. So you're reducing transmission, so you're also protecting the community. And if you reduce infections caused by both the resistant and non-resistant pathogens, then you also are reducing antibiotic use. And as you have less and less antibiotic use, then you reduce the resistance, the evolution of resistance. And so it sort of gets it gets you into a positive cycle of reducing antibiotic use, reducing resistance, and then needing fewer antibiotics. And that should hopefully perpetuate, which means that we can save the antibiotics for the people who really need them and also continue to decrease risk. So lots of mechanisms. So there's sort of 3 pillars to this. So one is expanding the use of already licensed vaccines. So this is the lowest hanging fruit. There's vaccines we already have for pathogens where antimicrobial resistance is a significant problem. And I've shown you already some data around pneumococcal vaccine. This is from the US showing the impact specifically on antimicrobial resistance. And so these lines show the reductions in antimicrobial resistance since the introduction of pneumococcal vaccines. 60% reduction in resistance to macrolides, so drugs like erythromycin and azithromycin, and then 80 to 85% reduction in resistance to cephalosporins, tetracyclines, and penicillins. So this is an incredible impact broader use of these vaccines, you could see similar impacts in many other countries. And then the other two pillars are developing new vaccines to prevent and control AMR, and expanding and sharing knowledge of vaccine impact. Because a lot of this, I think there's a lot of people who don't appreciate that vaccines have a role to play in antimicrobial resistance. People think about, infection control and antimicrobial stewardship, but vaccines don't always come front of mind. And so the way these pathogens have been divided is the sort of very, very high feasibility, where there's priority pathogens for which licensed vaccines already exist. So typhoid, strep pneumo, Haemophilus influenza, TB. And then the high feasibility, where there's vaccines in late stage development, and could be rolled out in the near future, hopefully. So E. coli, paratyphoid, gonococcus, and C. diff. And then the sort of moderate level, where there's going to be a bit more time and a bit more work. Again, E. coli, Klebsiella, Salmonella, Campylobacter, Shigella. And if you remember back to the beginning, a lot of these are the pathogens that were at that sort of left-hand end of the graph that cause a significant burden of disease. I think it would be remiss of me to talk about vaccines for preventing sepsis without talking about Group B streptococcus as, one of the main causes of neonatal sepsis globally. We don't currently have a vaccine for this, but there's a few inching closer and closer to market. So there's various conjugate vaccines and a protein vaccine that are in phase 1 or have completed phase 1 or phase 2 trials. And you can see that these are really targeting immunization in pregnancy from sort of 20, and the trials have been done from 21 to sort of 35, 36 weeks gestation to protect the mother, but more so to protect the newborn against neonatal sepsis. There's phase 3 trials expected imminently of some of these vaccines. So it'll be super exciting to see a Group B strep vaccine rolled out. And so hopefully that will be coming in the next few years as well. And then finally, I just want to talk a little bit about these controlled human infection models. So these are where you purposely infect people with a pathogen to try and make them have the disease, which can be really important in vaccine development, where it can be challenging to do large-scale phase 3 trials. And also if you have a lot of vaccine candidates, to sort of test them out on a smaller scale to sort of de-risk and expedite the pipeline. And so this is, fairly, I wouldn't say it's standard for anything, but it's been commonly used for a number of pathogens. And there's this sort of categorization where there's some pathogens where it's deemed that there's very few concerns, and that some of these have already happened. So things like malaria, pneumococcus, rotavirus, polio, flu, typhoid, and many of these pathogens, if not all of them, have had challenge studies done at some point. There's a few sort of lower down the list where might need a bit more caution, and there's a few more concerns that have to be dealt with. So E. coli, Shigella, norovirus, RSV, and dengue. And there's a few more where there's even more thought has to go into it, because there's either not sufficient treatment, or there's high risk of getting very severe disease very quickly, or some more chronic infections. But some of these have also already proceeded to challenge studies, and pertussis being one of those. And you can see COVID on this list. And early on during the COVID pandemic, there was a lot of discussion around whether human infection models would be needed. In the end, the phase 3 trials went relatively quickly, and we had highly effective vaccines very quickly. So it wasn't needed, but there was definitely a lot of preparation work being done for that event. And actually there was a public sign-up page, and tens of thousands of people signed up to volunteer for these even before they knew that much about the disease and before any treatments were available. So I just want to end the last couple of slides here. So this is a report from UNICEF, sort of on a slightly less positive note from this year. And so this graph here on the left shows the proportion of, or the number of children, I should say, in millions that have 0-dose vaccines. So it's all well and good having these amazing vaccines, but if they're not getting into people, then they're not that helpful. So in 2000, we had 22 million children in the world who had received no vaccines at all. And some of that may be due to vaccine hesitancy, but a lot of it really is due to just access and not being able to, keep cold chain and just physically the feasibility of getting vaccines to people. And then things were going reasonably well. We'd got this down to 15 million by 2010, and then sort of it was stable, maybe going down a little bit more, but you can see in the last couple of years, it's going in the wrong way. And clearly the pandemic has had a huge impact on that, as well as other sort of geopolitical events that disrupt societies. And so you can see 1 in 5 children are 0-dose or under vaccinated. 1 in 5 children in the world have no protection at all against measles. 7 in 8 eligible girls are not vaccinated against HPV. And so these are huge gaps currently that we have. But I did not want to end on a negative note, so I will just end by saying that, you know, as hopefully all of us will agree, that vaccines save lives, and these are data from the US showing, you know, these red syringes show the relative amount of disease for all of these vaccine-preventable diseases in the US, and then these percentage reductions that you can see for the most part, you know, 90+% reductions in some of these diseases in the US. And so if you have somewhere, this really goes to show that even with the vaccine hesitancy we have, if you can get reasonably high coverage with these highly effective vaccines, that the impact on sepsis and on infectious diseases is truly profound. So with that, I'm going to stop there and thank you again, and happy, I don't know if we're having questions after each speaker or we're going to save it all for the panel, but I'll hand it back over to Tex.
Thank you very much, Manish. I think we'll hold all questions at the end, and I'll ask David to collate the questions and sort of prioritize it for us so that, you know, there will be many things to be discussed. And I was very much amazed, I never thought of it, but the issue of vaccines and the so-called dance with AMR. And I think that's a very interesting area to explore. So I look forward to hearing more about that. The next speaker is a very good friend of mine, Emmanuel Nsutebu. He's a consultant infectious disease physician and adjunct clinical professor at Khalifa University. He's the chair of the Tropical and Infectious Disease Division at Sheikh Shagbut Medical Center in Abu Dhabi. He chaired the COVID-19 task force during the pandemic and chairs the African Sepsis Alliance, as well as he's on the board of the Global Sepsis Alliance. Emmanuel has been one of the big advocates for decreasing the burden and increasing access to care worldwide for sepsis. And indeed, the first time I met him was at the World Health Assembly in Geneva. And since that, he has really been one of my very good advisors. He's also a business and executive coach and author of a book, From Struggles to Success. Your struggles can make you better, stronger, and even more successful. It was stemmed from someone who died from sepsis and his journey in trying to reconcile the death of a friend, etc. It's a good read. But he will be talking about the importance of antimicrobial stewardship in reducing the burden of sepsis. And as you can gather from the theme of Manish's talk and Emmanuel, the issue of AMR is very important in the world. And it's one of the biggest threats, according to the World Health Organization. But we cannot speak about AMR without speaking about sepsis and vice versa. So I'll turn it over to you, Emmanuel, and look forward to hearing you.
Thank you very much, Tex, for that kind introduction, and thank you to David and the organizers for asking me to speak at this event. I'm just going to share my slides, and then we should be able to start. So thanks again for inviting me to speak at this event. It's quite late in Abu Dhabi here. It's 1 a.m. So excuse me if I may sound a bit sleepy. So I've been asked to talk about the importance of antimicrobial stewardship in reducing the burden of sepsis. And I'm going to use experience of sepsis improvement in the UK. And I worked as a medical director for deterioration and sepsis in Liverpool and clinical lead for sepsis in the National Health Service in the UK, as well as experience of sepsis improvement with the African Sepsis Alliance and my current hospital in the Abu Dhabi, where I chair the Tropical Infectious Disease Division. So in terms of objectives, we are going to first go through the importance of antimicrobial stewardship and resistance. Then I'll describe the principles of good antimicrobial prescribing in patients with sepsis and provide some tips as well, and then highlight how we may improve antimicrobial stewardship in sepsis management, and also use some examples from different parts of the world of ways of improving stewardship in sepsis improvement. Now, this slide is a really important slide. And as a chair of the African Sepsis Alliance, when I speak to policymakers in Africa and other parts of the world, we always have a discussion of how does sepsis fit within the different programs that are ongoing. And so how do we conceptualize sepsis improvement as a whole? And it's always a very tricky thing to describe. But you see in the middle in red here, most of our focus tends to be on recognition and treatment of sepsis. And so it's mainly around strengthening health systems to recognize and treat severely ill patients with sepsis included, or improving recognition and treatment of patients with sepsis, which fits very well with recognition and response to emerging infections. So often in raising the profile of sepsis, we'll focus on strengthening health systems and also on emerging infections, especially with COVID being quite topical at the moment. We've also just had presentation and discussion about post-sepsis care, which is also really important. And so to conceptualize sepsis improvement is also about post-sepsis care, post-discharge care and follow-up. But in this presentation, we're focusing on prevention of infection. And all these various aspects of vaccination, which Manish has just detailed for us. Hygiene and sanitation is part of also sepsis improvement, preventing infection. I'm going to be talking about antimicrobial resistance and stewardship, which also links up with sepsis improvement. And then infection prevention and control, reducing risk of healthcare-associated infection, which is overall part of patient safety. So these are all facets of sepsis improvement, the core being recognition and treatment of sepsis, but it links to all these different programs. And so when we come to improving sepsis management, it's a balancing act between antimicrobial stewardship and sepsis improvement. And they're two sides of the same coin. And sepsis improvement can potentially improve or worsen antimicrobial stewardship and vice versa. And if we don't get antimicrobial stewardship right, we can drive complications, sepsis, mortality of sepsis. And I'm going to talk through this in my presentation. And so on the one hand, this is a forum where I don't need to stress the importance of sepsis. We have a large number of people, estimated 50 million cases of sepsis globally, with around 11 million deaths every year, and highest burden in low resource settings such as African continent, with 17 million cases of sepsis a year and estimated 3.5 million deaths every year. So a third of cases and mortality in sub-Saharan Africa. On the other hand, we've got antimicrobial resistance, also more significant in low resource setting, associated also with worse outcomes all over the world, higher mortality, length of stay, complications and costs. And we know from estimates that by 2015, if we don't turn things around, we'll have around 10 million deaths related to antimicrobial resistance per year if we don't do something significant to improve stewardship and reduce antimicrobial resistance. There are also very few new antibiotics being discovered, and we're now more recycling old antibiotics or combining previously discovered antibiotics in order to improve the effectiveness of our current antibiotic tools. Antibiotic resistance in hospitals is also driven by antibiotic misuse, and I'll be going through some tips of how we can improve antibiotic use in hospital. And so just like we talked about the same issues of vaccination, we're in a vicious circle where we have an increase in numbers of patients with sepsis, infection and sepsis. We then increase our antibiotic use and often misuse. That drives resistance. The antibiotics become less effective. We have less effective treatment, increases complications with length of stay and then new resources, and the cycle continues. So what is the evidence that there is inappropriate antibiotic prescribing and use in hospitals? Well, there have been multiple studies from different parts of the world, and the summary is it's estimated that around 1/3 to 50% of patients at any point in time in hospital are on antibiotics. So it's one of the most prescribed drugs in hospital. And it's also estimated from surveys that around a third of patients on antibiotics at any point in time are on antibiotics inappropriately. And that also includes surgical prophylaxis, which in a third of cases is inappropriate. So we've got quite a lot of work to do to improve use of antibiotics. In some hospitals, it's even estimated that more than 50% of patients on antibiotics are prescribed antibiotics inappropriately. And this in itself can drive resistance and then drive complications such as side effects and predisposition to developing Clostridium difficile, for example. And we've seen this within the COVID pandemic. The COVID pandemic has shown us how initially at the beginning of the pandemic, when we didn't know what worked in terms of treatment for COVID, and there was overuse of antibiotics in many parts of the world, we saw a rise in antimicrobial resistance within hospital, as well as a rise in healthcare-associated infection, partly linked to infection prevention control, breaking down in hospitals, but also due to antimicrobial use. And there are reports all over the world of outbreaks of candidemia linked to line infections, partly due to antimicrobial overuse in hospital. And so to conclude this slide, I'd like to just highlight this quote, which is a very poignant quote from the UK Chief Medical Officer in 2008, Sir Liam Donaldson. Every antibiotic expected by a patient and every unnecessary prescription written by a doctor is potentially signing a death warrant for a future patient. And that's as well as unnecessary use in animals or in agriculture. And we don't always think about antimicrobial use. We think about our immediate patients in front of us, and we don't actually appreciate that if we misuse antibiotics now, we're potentially signing a death sentence for the next patient or future patients. So why is sepsis improvement, why can sepsis improvement also affect stewardship? First is the signs and symptoms of sepsis, as you know, are non-specific, and there are many things, many different illnesses that will mimic sepsis and behave like sepsis and often can be misdiagnosed. We also have a pressure to administer antibiotics in a timely manner because we know timely antibiotics save lives. Certainly septic shock within 1 hour because of data suggesting increasing mortality around 8% with every hour of delay. Now, Surviving Sepsis campaign guidelines recommend for other cases of sepsis, not septic shock, that antibiotics can be administered within 3 hours. So there's still pressure to give antibiotics as soon as possible. We also know from surveys from various emergency studies amongst emergency departments that up to 50% of patients diagnosed with sepsis may not actually, or managed with sepsis, may not actually have sepsis. And so all this may lead to overuse of antibiotics in patients with sepsis as we drive recognition and initial management of sepsis. And so the sweet spot we want to arrive at with quality improvement in sepsis is using antibiotics appropriately and reducing use of antibiotics and reducing resistance, whilst at the same time reducing mortality. So the bottom right box, all in green, of improving mortality with using antibiotics for the right patient with sepsis appropriately, and at the same time reducing use and resistance. And so the focus of how we do that is about stewardship. And contrary to perceptions, that stewardship is as an ID physician, often my colleagues will accuse us of stewardship being about just going around stopping antibiotics. It's not about stopping antibiotics, it's about improving outcomes for patients and making sure the right patient gets the right antibiotic. But it's also about reducing toxicity and side effects related to antibiotics. We also see as an ID physician a lot of morbidity and also, unfortunately, mortality related to side effects of antibiotics. And we also, one of the objectives is reducing resistance and also costs related to misuse of antibiotics. And so the principles of stewardship, antimicrobial stewardship, is the 6 Ds, and that is about making the right infection diagnosis and making sure that the right patient then receives the right antimicrobial at the right dose, the right route of delivery, duration, and then de-escalation to oral or narrow spectrum antibiotics, the 6 Ds of stewardship. And so put it another way, this is the framework which you use in the UK, antimicrobial stewardship is about identifying a patient with bacterial infection that requires antibiotic, then starting SMART, and then focusing within 48 to 72 hours. And so taking a relevant history with relevant allergies, deciding on what the diagnosis is, complying with the local prescribing guidelines for the hospital, region, or national guidelines, then documenting quite clearly what the reason is for prescribing antibiotics and when it needs to be reviewed, what the stop date is, and then taking cultures, especially blood cultures in patients with sepsis, so that we can then refine the antibiotics within 48 to 72 hours. And then at 48 to 72 hours, making a decision about de-escalation, either stopping the antibiotics because there's an alternative diagnosis and it's no longer needed, or switching to intravenous to oral, changing to narrow spectrum antibiotics, or continuing and reviewing within another 48 to 72 hours. Or lastly, the fifth is outpatient parenteral antimicrobial therapy, being able to discharge the patient to receive antibiotics on an intravenous antibiotics on an outpatient basis if there is no oral option. And so you would all recognize in your hospitals in the West, not necessarily in low resource setting, that all your hospitals would have stewardship programs with different levels of complexity. And we have evidence-based tools that are key parts of stewardship programs, and that involves education, for example, regular audit and timely feedback to clinicians about prescriptions and management of patients with infection, developing treatment guidelines for infection that are used within the hospital and promoting their use, encouraging automatic stop dates for specific antibiotics so that they have to be reviewed by the clinicians, prior authorization and restriction of certain antibiotics so that they are not used indiscriminately, and also in developing and implementing clinical decision support tools to help clinicians make decisions about which infections to treat and what antimicrobials to use. And then also using diagnostic testing, diagnostic tools, whether it's biomarkers or microbiological tools, to optimize diagnosis and also management of patients. And all these are tools which we use within stewardship programs to optimize use of antimicrobials within a hospital. So let's move to what can be done to improve stewardship in sepsis. And I'm going to go through this in sort of 5 key points. First is education, and then I'm going to talk about integrating sepsis improvement with stewardship. These are programs that need to be hand in hand, and I'll use a UK national example of commissioning for quality and innovation. Then we'll talk about the use of early infectious disease and antimicrobial stewardship program interventions in patients with sepsis, and some examples from different parts of the world. What is the role of biomarkers in brief? And I'll mention a trial which is ongoing in the UK, which I helped develop and still part of, called the UK Pronto trial. And then lastly, I'll mention rapid microbiological diagnosis and identification of pathogens from blood culture identification panels. So education is a key part of every quality improvement program, and it's just the same for stewardship and sepsis. And what I want to do here is just highlight some important tips which I tend to stress within our hospital and also use quite well in Liverpool. And the first is, as a clinician, it's very easy to start antibiotics, but it's very difficult to stop. So clinicians, especially in the emergency department from the floor, need to think deeply before you start an antibiotic. Does the patient really have a bacterial infection? Is it sepsis? And why do you think it is sepsis? Have cultures been taken before you start antibiotics so that we can confirm the cause of the infection and also de-escalate later on appropriately? And is it really needed? Are you really treating infection, or are you just trying to treat the pathogen because there's a positive cultural result? Secondly, choosing antibiotics for treating sepsis according to the source of infection. often when we develop sepsis improvement programs, clinicians may feel the pressure to just prescribe broad spectrum antibiotics, and it tends to be the easy option without thinking through what is the source of infection. If the patient has cellulitis and sepsis, you give antibiotics for cellulitis, unless the patient has septic shock and you're not sure of the source where you're giving broad spectrum antibiotics. If you've made a diagnosis of pneumonia, it's clearly pneumonia, then give antibiotics for pneumonia to treat sepsis caused by pneumonia. Thirdly, controlling the source of infection. Not only thinking through antibiotic use, but also what can you do to control the source of infection, because that helps to limit the duration of antibiotics and also improve outcomes. Also, using the hospital antimicrobial guideline, which should be developed based on the local antibiogram. And not following your hospital antibiotic guide helps drive misuse of antibiotics. And that's really an important tool. And so having systems to help clinicians use their local antibiotic guide. And we have an antimicrobial app in Abu Dhabi, which has really helped significantly improve access to our hospital antibiotic guideline. It's called First Line. In addition to that, antibiotics are rarely, over more than 5 to 7 days, are rarely needed for infections. Most infections we know now need maximum 5 to 7 days of antibiotics, whether it's pneumonia, urinary tract infection, intra-abdominal infection. Unless it's a deep-seated infection, 5 to 7 days of antibiotics is often more than enough. They do not need more. Also, narrowing the spectrum of antibiotics whenever it's possible and using the most narrow spectrum antibiotics. If somebody has a methicillin-sensitive Staph aureus bacteremia or infection with sepsis, using oxacillin, flucloxacillin, the most effective antibiotic for that organism. And so whenever you can narrow down the antibiotic, narrow down based on sensitivities. In addition to education, the second point is about integrating sepsis improvement with stewardship, whether it's at hospital level, regional level, or national level. And the example I want to mention here is the National Commissioning for Quality and Innovation project, which was initiated in the UK in 2017. And it was a sequence, Commissioning for Quality and Innovation project, where hospitals had to achieve certain targets or else they would not get 0.25% of income. And so we help focused hospitals minds around sepsis recognition and initial management. So patients with an early warning score of more than 3, equal to or more than 3, had to be screened for sepsis, and the hospitals need to demonstrate that patients are being screened for sepsis. For patients that screen for sepsis and are diagnosed with sepsis, documenting and demonstrating that they received antibiotics within 1 hour, and linked to the sepsis sequence was also antimicrobial stewardship, confirming that there was documented review of the antibiotics at 72 hours. And so this National Sepsis Improvement Community for Quality and Innovation project not only linked sepsis improvement, but also stewardship. And I don't have data to show you, published data, but the anecdotal data from people who were involved in it, I was involved in it, but our pharmacy lead was kind of clear from the data he showed us in meetings that there was no rise in antimicrobial consumption as a result of this national sequence in the UK. The third aspect is about using early antimicrobial stewardship teams for sepsis improvement. And there have been a number of publications that have looked at the impact of antimicrobial stewardship teams on sepsis improvement. The first is this one on the top left-hand corner, which was a study from Australia looking at the role of antimicrobial stewardship in clinical sepsis pathways. And it was a prospective interventional study where they compared patients with sepsis diagnosed via pathway that were reviewed by an infectious disease fellow and those that were not reviewed by infectious disease fellow. So this involved, the intervention was infectious disease fellow review of patients initiated on a sepsis pathway. And what they found in this study was an increase in appropriate use of antibiotics, but no difference in mortality, lengths of stay, or intensive care admission between patients when an ID fellow was involved in their management. The second, on the bottom left-hand corner, is a study from the US where patients in the emergency department were assessed and compared two arms, patients diagnosed with sepsis who had infectious disease consultation, and patients diagnosed with sepsis in emergency department who did not have infectious disease consultation. And it was interesting that although what they found was an improvement in appropriate use of antimicrobials. That's expected because they had infectious disease consultation, but there was a 40% reduction in mortality in patients with sepsis who were reviewed within 12 hours by an infectious disease physician. And so the message was there's a potential maybe to improve outcomes by early infectious disease consultation. However, this is clearly not something that is scalable around the world and even in most developed countries. And the last, on the right-hand side, bottom right-hand side, is the first randomized control trial of an early antimicrobial stewardship team intervention, which was carried out in Australia. And these were patients who developed sepsis in the non-ICU setting, and they were randomized to having an early antimicrobial stewardship team review within 48 hours or no review and just managed by their team. And in this study, what they also found was improvement in antimicrobial stewardship, improvement in appropriateness of antimicrobial therapy in patients with sepsis, but no difference in mortality or length of stay. So the message is perhaps there's a potential for using infectious disease expertise, stewardship expertise early to improve antimicrobial stewardship and use, and that may have an impact on outcomes, but seems to mainly have an impact on use, and perhaps we need more research on this topic. The fourth aspect I'd like to highlight that can potentially improve antimicrobial stewardship and sepsis management in biomarkers. Now, this is not a talk on biomarkers, and we can spend the whole evening talking about biomarkers here. However, I just want to mention procalcitonin. Although it's not a recommended tool to use to make a decision about whether to start antibiotics or not in patients with sepsis, but there is an ongoing study in the UK called the Pronto trial, which I also helped develop and still part of, which is procalcitonin and National Early Warning Score 2 evaluation for timely identification of sepsis and optimal use of antibiotics in the emergency department. And what they're doing in this trial, randomized control trial, is using point-of-care procalcitonin in addition to National Early Warning Score with an algorithm to assess whether they can reduce initiation of antibiotics in the emergency department for patients suspected of having sepsis, and whether they can substantially reduce antibiotic initiation in the emergency department without having an effect on 28-day mortality. So it's a parallel two-arm open-label individual randomized control trial, and it's being carried out across multiple sites in the UK, recruiting more than 7,600 patients over 2 years, and suspected to end this year. So hopefully next year, we should have the outcome of this study, and it may help us with answer the question of, does procalcitonin, not on its own, but using an early warning score, can it potentially help reduce initiation of antibiotics and antimicrobial use overall without affecting outcomes? Then lastly, I'd like to mention rapid blood culture identification. And there are multiple different methods. The traditional method of taking blood cultures, incubating them, waiting for 24 to 48 hours for them to be positive, and then identifying what pathogen it is, and then sensitivities, it's still what is used in most hospitals around the world, and when it's available. However, increasingly we have rapid blood culture identification methods. There are different techniques. One of the ones I've highlighted here, without any particular conflict of interest, is rapid PCR-based blood culture identification panels. This is multiplex panels that can identify at least about 20 to 30 different pathogens, and also have ability to identify potential resistant markers. So not just different pathogens, but whether they may be resistant to certain antibiotics. This study I'm highlighting here was done in the UAE, and there have been multiple studies in other parts of the world assessing the effectiveness of rapid PCR-based blood culture identification panels in improving diagnosis of patients with bacteremia. The bottom line from all these studies is they seem to improve time to identification of the pathogens in blood culture. They also seem to improve time to starting appropriate antibiotics in patients with bacteremia. However, the only studies that have seen an impact on improvement in outcomes, such as mortality, ICU admission, and length of stay, are when there's link between the use of this technology and also a stewardship team also involved in reviewing the patients and helping make decisions about stewardship. So it's this rapid blood culture identification panels, in addition to stewardship, seem to have a significant impact on outcomes, in addition to improving intermediate measures, outcomes such as time to identification of pathogens and time to appropriate antibiotics. So I'll conclude by saying, I hope I've highlighted the fact that antibiotic misuse drives resistance, and therefore we need to protect and use antibiotics carefully. Antimicrobial resistance can affect sepsis outcomes, so part of sepsis improvement is also stewardship and controlling antimicrobial resistance. Sepsis improvement programs and antimicrobial stewardship programs should be really integrated and work hand in hand. And promoting stewardship principles can improve antimicrobial use and improve management of sepsis also. There have been a number of studies that have looked at biomarkers and rapid diagnostic tools, as well as interventions such as stewardship program being involved in sepsis programs, but research is needed really to assess the effectiveness and especially around outcomes, hard outcomes such as mortality, length of stay, and ICU admissions. And I'll stop there and look forward to questions at the end. Thank you.
Thank you very much, Emmanuel. In my eagerness to hear my colleagues speak, I did not realize that I was supposed to give the first, speak first and then introduce you guys. So now you'll be subjected to hearing me. I think if you can log off the screen, Emmanuel, and then I will share my slides. Okay.
Tex, this is David. I couldn't think of a better closer to make the final penalty shot of this soccer match.
Well, I think it makes it a little more difficult trying to incorporate everything, but I will try my best. And here is that I'm going to speak about early detection and treatment and advocacy as is needed to decrease the burden. And much of what I'm going to say will tie into what my two esteemed colleagues has already spoken. And one might look at it and say, well, this issue of early treatment is problematic, and it may be working adversely to antimicrobial resistance. But I think bear in mind throughout what I'm going to say about the importance of early antibiotics, what Emmanuel has just said about the stewardship. So the two topics I'm going to speak about is early detection and treatment, improve outcomes, and then speak a little about advocacy and where we have gotten with advocacy and what we need to do. The issue of early treatment to improve outcomes is very, very important. And in fact, when we look at the 70th World Health Assembly, improving diagnosis and clinical management of sepsis, one of the things it said very clearly that the majority of sepsis deaths and development disease are preventable, which is why we've been speaking of so many things. You've heard the importance of prevention, vaccination, sanitation, etc. And you will also hear, see one of the important things that was the World Health Assembly stress was early recognition and treatment of sepsis as an emergency. And you heard Emmanuel mention the quality of healthcare system, and access to appropriate care is an enabler of early treatment and as an emergency. Now, before going on to the early treatment, again, I'd like to reiterate what Manish spoke about, is the issue of prevention. And this is a study we did several years ago, and we did this in Brazil, looking at databases over a 15-year period of hospital admissions for children with sepsis. And one can see during this period of time, there was improvement in vaccination rates, very high over the 90s, sanitation, trash collection, water treatment, national nutrition, oral rehydration use. And one can see in this upper graph, the number of hospital admissions for children with sepsis decreased from about 65 to 70,000 down to about 25,000. So a marked decrease, admission decreased 20%, but in-hospital mortality during this period of time for all ages remain unchanged. So the importance, much of the gains we made in sepsis were made prior to the introduction of antibiotics in hospital care. And we need to not lose that, because when 85% of sepsis cases and 85% of deaths occur in low and middle income countries with minimal resources, I think what Manish showed about the issue of vaccines and those things play a very, very, is of high importance in decreasing the burden. Now, quality of care matters. And this, the issue of early treatment or interventions that would prevent deterioration in the long run was recognized from the days of Machiavelli. And in fact, he spoke about sepsis, and he called it hectic fever. And he was equating it to countries in turmoil. And he said in the early stages of hectic fever, just like a country in turmoil, the signs and symptoms are subtle. It's difficult to recognize, but easy to suppress. But as you go down later on, the signs and symptoms become very obvious, and then it is difficult to suppress. And this is a study report a few years ago looking at severe sepsis and septic shock among adults in critical care units in Australia. And during this period of time, there were several interventions that they put in place. One can see if you can prevent the patient condition from deterioration, that's the best outcome. But as they deteriorate along the slope, they intervene with clinical reviews earlier, rapid response, etc., and advanced life support care. And one can see the early stages, you can get them back to usual residence and rehabilitation, but with the advanced life support, they may even die or require a lot more care. And in many parts of the world, they do not have the luxury of providing this sort of care. Now, we know that this is a study in the BMJ here that shows that pre-hospital delay is an important risk factor for mortality in community-acquired bloodstream infection and sepsis. This is the probability of survival with no antibiotics over 6 days. You can see there's marked deterioration in the probability of survival, whereas immediate antibiotics, they're more likely to survive, and deferred antibiotics, they're sort of intermediate there. So again, antibiotics need to be given when there's suspicion of sepsis, but it has to be wedded again to antimicrobial resistance and antimicrobial stewardship programs, as Emmanuel has said. Now, this is easily said and done in the rich countries in the world, but again, I take a global perspective. In many parts of the world where there are no tests that is available, laboratory of resources are very poor, access to care is very poor, and also we do not have the luxury to wait. The 3 hours in sepsis that for patients to declare themselves because they may go to require highly acute care and expensive care, which is not available. So it's always a balance depending on where you are. And in life, as we all know, context matters. Now, this is another important sort of group of studies showing the early antibiotics and QI efforts that improve survival. On the left is a study from Chris Seymour, where they looked at antibiotic administration, time of administration of antibiotics, and you can see 1 to 12 hours on in-hospital mortality. If antibiotics is given within 1 hour, you can see the mortality is about 22, 23%. But for every hour, the mortality increases. And in fact, this was first shown by Anand Kumar here in Winnipeg, Canada, where I think it was for every hour delay, there was, I think it was about 3 or 5% increase in mortality. Now, this is a very important, and I'll come back to this one, this slide from Marcus Friedrich. The Governor Cuomo signed a law, the Rory Staunton law, which I'll come to later on. But the bottom line is that all hospitals in New York were expected to put screening tools in place for identification of sepsis and a bundle in place to treat. And over a period of several quarters, you can see in a matter of 3 or 4 years, there was a reduction in hospital mortality. This is in the adult population from 32 to 22%, and this was within 5 years. And hence, importance of having quality improvement that drives the use of early antibiotics, drive the use of bundle of care. And I will show you where a bundle of care is important, whereas the antibiotic alone is very important, but may not be the end of the story. This is a very similar the New York group, which I had the good fortune to work with them on. This is of 54 hospitals, and these are pediatric patients. And when we look at it, time to complete a 1 hour bundle, again, from 0 to 4 hours, mortality is about 5 or 6%. And when it was completed within, say, one hour, but as we go up, it's about 16% if the antibiotic was given within 4 hours. Sorry, this was time to complete the entire bundle. So the bundle consisted of antibiotics, fluid, taking the lactate, and monitoring. Now, these are a few studies that I will mention that in pediatrics. This one is from Texas, where you can look at these statistical control charts, time to first bolus, time to third bolus, and time to antibiotics. And these are the simple interventions in their bundle. And one can see that there was a high variation initially, and over a period of time, with the appropriate interventions, one can see the time to bolus was very quick. It did not vary much, same as the third bolus and same as antibiotics in their group of severe sepsis. This end result was need for mechanical ventilation decreased from 20 to 3%, vasoactive drugs from 16 to 10, and mortality also decreased from 4% to 2.5. We look at another one. This is from Utah. And again, they looked at 3 things again, given fluids, 20 mLs per kilo within an hour, checking the lactate and giving antibiotics within 3 hours. And one can see once they started to achieve their goals in these statistical run charts, there was a decrease in mortality from 7 to 6.1. Length of stay decreased also. And if the 20 ml of fluid was given in the first hour and antibiotics within 3 hours, you can see there was a marked decrease in mortality from 8 to 3%. Another one, this is from Boston Children's Hospital, and basically they also put together a bundle, as you mentioned, antibiotics, fluid, getting vascular access, quick recognition, and inotropes if needed. Patients who receive 60 ml of fluid within 60 minutes had a 57% shorter hospital length of stay than children who did not, and complete adherence, bundle adherence resulted in 57% shorter hospital stay. Another example, this is from a national quality improvement program campaign in Ireland, which was supported by Leo Varadkar. At the time he was Minister of Health, and also had the good fortune of being there at the time and on the inauguration of this and speaking at these meetings had been set up. And one can see the crude mortality decreased over a period of about 7-8 years from 25% to 18%. This is in Germany, very same sort of thing but you need a quality improvement and you need leadership and dedication at the hospital level. This was also in New York here, Northwell Health, where the CEO, Michael Dowling here, was very instrumental in supporting us during the formation of the Global Sepsis Alliance. But as again, one can see the overall septic shock and septic mortality decreasing over time in these systems. So I think that these are important, but again, when we think of it globally, these are mostly what we see in the developed world and where we have resources. One of the things in countries with very little resources is obviously we have to use clinical syndromes, etc., rather than laboratory tests. And we have to be very judicious in the amount of fluids we give, because if we give too much fluids and children or adults get into respiratory failure, then we are going to be in big trouble. The Lancet had a commission on sepsis a few years ago, and it struck me that while this paper in Nature in 2000 by Declan Butler spoke about crossing the valley of death, and what it was is that the researchers are on one side with a test tube, etc., and the clinicians are waiting on the other side, and the time it takes to get the findings of the research implemented into clinical practice is so long that many of the patients are dying in the middle. And while this was in criticism of the US National Institute of Health and a small amount of funding for clinical and translational science centers, I bring this up because the Lancet Commission, there was an editorial, and I think that's written by Liz Molyneux, who wrote, the question was, what do you do for the poorest of the poor for sepsis? And she spoke about the science of delivery, basically implementation science, because we know what works. So I hope I've been able to convince you that early detection and treatment improves outcome. But then two things, you remember early on, we still have the post-discharge issues and follow-up, obviously, that needs to happen. Also early detection and treatment should be coupled with good stewardship programs. And also we should never forget prevention, because that really ensures the best outcome. Now, I'd like to change gears a bit and speak about advocacy and why this is important. And in Manish's talk, he mentioned the issue of the vaccine, the low-cost vaccine for the meningococcal belt in Africa. And I think that one of the things that he did not really have time to stress is the importance of advocacy, because without advocacy for the vaccine to be low cost, that would never have happened, and the benefits that we've accrued there in sepsis would never have happened. By the same token, there are many examples of where advocacy has been important for this disease, and I'll give you a quick rundown. So William Osler, who is thought to be the father of medicine, said humanity has three great enemies: fever, famine, and war. And of these, the greatest by far, the most terrible, is fever. And you've heard the figures about sepsis. And the studies most quoted so far is our 2020 study with Christina Rudd, which we did. But then in 2019, you can see the population, the number of deaths from sepsis has increased compared to COVID, which is about 7 million, and the cancer is almost 10 million. AMR attributable deaths and associated deaths, one can see here 1.27 and 4.97 million respectively. Now, these are not trivial numbers, but again, we have to put it into context when we think about globally patients with sepsis. So while AMR and AMR-associated sepsis kills, sepsis by itself is a major killer. And in the United States, one can see $62 billion is spent. It has great economic impact. Now, this is a study that was done by my colleagues, John Howe and Tan, from South Korea. And what they did, they looked at severe sepsis in children and outcomes over a period of years in the developing world with the blue, and they changed the developing world, the yellow, that's low middle income countries, and the blue are the higher income countries. And one can see over a period of time, the mortality from sepsis has decreased, but the lines are parallel, and case fatality rate in high countries about 19%, over 31% in low countries. And the question is, why is this? Well, it's multifactorial. And I will come back to that when you think of the Sustainable Developmental Goals, which means that clinicians at the bedside alone are not able to solve these problems. These are societal problems. It has great overlay of socioeconomic benefits and socioeconomic deprivation, gender inequities, etc. Now, so Laurie Garrett wrote this book quite a few years ago. It's called Betrayal of Trust and then the Common Plague. And she predicted the Ebola epidemic about 10 years before it came. We had it. And she said here, advocacy, when you have global issues, and sepsis is a global issue, all of us felt it in the last 2 years with the COVID. And in fact, as Paul Farmer said, that borders in the world act as semi-permeable membranes to infection and diseases. But drugs, money, goodwill, policies stop at borders. And you can see that that is not the way that is going to end any pandemic. So she said to prevent pandemics, we need everyone's pharmaceutical, laboratory, government, and health forces worldwide need to be marshaled. And we need the fruits of scientific labor from everyone, from politics, sociology, economics, and even elements of religion, philosophy, and psychology. And while the last three, religion, philosophy, and psychology, may sound surprising to some in our world, I can tell you it has great overbearing in the issue of vaccines and vaccine hesitancy across the world. It has the issue of delivery of care in poor countries, especially in rural areas, etc. This was a quote that was from a pediatrician. It was Dr. Farber, who was an oncologist working in pathology at the base of Boston Children's Hospital. And he has said he had seen too many kids die. And he realized that a campaign for any disease is like a political campaign. You need icons, mascot images, slogans, strategies of advertising, as much as the tools of science. For illness to rise to political prominence, indeed marketing, it has to be transformed politically before it can be transformed scientifically. And I think we've seen that again and again, because in the United States, you may recall, some of you may recall, that the March of Dimes started when women went with baskets collecting dimes, and the polio was not the biggest problem in the country, but it became a big problem because the president had polio at the time. So with sepsis, we started this Global Sepsis Alliance in 2010, hasn't been that long ago. And we had five founding organizations: International Sepsis Forum and the World Federations of Nursing, Intensive Care, Adult and Pediatric, etc. And being the president of the World Sepsis at the time, I had the good fortune. We launched this in New York, Long Island, and then we decided from there that this was not good enough. While we got enough press, there were many things we needed to do. We started a World Sepsis Day, and many of you all over the world, for which I'm grateful, have been involved, and it has been growing again and again. Other things. The issue of zero preventable deaths, as you've heard, the other thing we needed to do was get a resolution from the World Health Assembly. We got a resolution in 2017, but sepsis is something regional, it's on the ground. And for that, we developed regional alliances, of which Emmanuel is head of the African Alliance. But these alliances are instrumental in making the resolution a living, breathing document, because once you get a resolution, you're only about 25% there. And we are working diligently with that. But it's only advocacy in these regions. And I know, for instance, in Africa, there have been several resolutions, the Khartoum resolutions, the Rwanda resolution, the Uganda resolution, that has all been creating great excitement and getting the work done there. I think that one of the issues, I had a meeting yesterday with a philanthropy organization asking about sepsis. And they were asking questions, well, what do you do? What is, how do you treat, et cetera, and why can't we have a universal thing? And I said, there are several things you have to think about. With sepsis, it's such a very complex thing. We have to not think about one or the other. It's not for the false dichotomies we've created. We have to have integrated thinking. So it's not prevention or treatment, it's both. It's not vertical or horizontal, it's cross-cutting teams. It's not primary or specialized care, it's both. Infections and non-communicable diseases, because 50% of the patients who died in that Lancet study, the infections were they also had non-communicable diseases with the infections. It's not knowledge or action only, it's both. Social determinants of health and healthcare both comes into it. And we need to think both globally and locally when it comes to infectious disease. I'll just go this briefly. As you can see, this is a sustainable goal which we will be judged with over the next few years. One can see while global health and well-being is in the middle, the issue of ending poverty, prioritizing the needs of the poor, making sure you deal with nutritional issues, zero hunger, quality education, gender equity, clean water, the environment, good medicines, etc. About 10 of those play into the issue of sepsis. And I think that we have to realize that and also advocate and form sustainable partnerships. One example of formal education is a social vaccine, as people said. This study showed that if a mother has high school education, up to high school education, which under 5 children has a 31% less chance of dying, and if fathers have the same education, it's 17%. So education is very important for families. This is another thing of engagement of families. This is what started the New York project with this young man, Rory Staunton, died from sepsis, unrecognized. And his father and mother, Karen and Olate, as you can see here, they started this movement. I've worked closely with them over the years, and I'm pleased to see that what they've done. In fact, now for the first time in the United States, Congress has appropriated money for sepsis issues. And now the question is, why do we advocate for it globally? We cannot think and have blinders because it's a moral issue. We need to take care of others. And one can see what the COVID did. It really affected us all. And there are two presidents of the American Society of Tropical Medicine. One says, no country can live to itself in disease prevention. A failure of one is a failure of all. And Richard Gorant a few years ago said, the solution of children's problems stuck in tropical countries are the solutions to our problem. Of one thing I'm sure, how they and the disadvantage around the world fare is what will clearly determine the destiny of us all. And it's playing out across the world with wars, with mass migrations, with climate change, and we can go on again. And if you're not a moral person, it has consequences. These are some of the diseases across the world. We don't have several of the diseases there, including the COVID here. But when you look at the flight patterns across the world, this is what you see. Thank you very much. And I hope everyone will join the Global Sepsis Alliance in our fight to have zero preventable deaths. I'll stop there.
Tex, thank you so much, and Manish and Emmanuel, for your wisdom. I am always amazed by how much I learn from all of you, and about how I'm humbled by the three of you and your world experience. I was going to, awesome, thank you very much, Tex. We have a couple great questions, and I'm wondering if Emmanuel, if you're still here, you may have gone to bed, and that's okay too. If you could turn on your video, and Manish, thank you so much. Thanks for staying up so late. I would offer you my favorite form of caffeine, a chocolate-covered espresso bean, but I don't know how to hand it to you through the screen. We have a couple questions, and Tex, maybe I'll read them to you and let you start or choose who would be best to answer. Would that be okay?
Sure.
Great. How do you see the vaccine resistant movement? We've seen a lot of people resistant to vaccine, in particular over the past few years of mandated vaccines. How do you see this resistance movement impacting the ability to effectively release and garner uptake of new and upcoming vaccines, or even the current well-established vaccines?
Normally, I'd say to protect my colleagues, we'll pass on that one, but Manish, go for it.
Thanks. I mean, I think that's a great question, and I think in 2019, vaccine hesitancy was declared a global health emergency alongside antimicrobial resistance and some of the other issues. I think it's important to realize that it's a continuum. So you've got people who accept all vaccines, and certainly at least in North America, that's around 70% who will just, if they get a recommendation, they'll go ahead and get them. And then you've got the sort of in between people who either want to delay or have some and not others, or a little bit unsure and have questions. And I would say that's, maybe 25 or so %. And then you've got the sort of true anti-vaccine, which at least in our context is about less than 5%. I think the most important thing is to just acknowledge that this exists and that it's a spectrum. And I think it's really important for people to try and understand the local factors. I often use an example that's more local to Canada, of two small towns in Alberta, which are almost right next to each other, and one has almost 100% vaccine uptake, and one has extremely low vaccine uptake. And so I think there's really micro factors that are important. I think increasingly, the move is to talk about vaccine confidence and try and frame it more positively rather than vaccine hesitancy. And I love, if you have time, people who are more interested can look at there's a great website done by Heidi Larson's group at the London School of Tropical Medicine called vaccineconfidence.org, and they've recently developed a framework where they've sort of identified 5 pillars of vaccine confidence, and that includes trust. So trust, and particularly trust in a healthcare provider. And whatever we think about the media and social media, a strong recommendation by a trusted healthcare provider still trumps almost everything else. So that's really, really important. Safety and effectiveness. So it's important that we continue to do good research and good studies and have good surveillance in place for these things, even after vaccines are implemented. Importance, so education around the importance of sepsis in this case, that these are really, fundamentally important diseases that we're trying to prevent. And then the fifth, which maybe isn't so much thought about, is religious compatibility. And I think we learned a lot about that during COVID, of having alignment with people's religious beliefs in a lot of the world is really, really important.
Yeah, no, thanks very much, Manish, because I know for a fact that there were vaccine hesitancy problems, and in fact, some vaccine workers were killed in Pakistan and I think in Nigeria because of the issue of religion. Well, it was thought at some time that the vaccine was going to make women or the children sterile. The other thing with the vaccine was that it was going to spread HIV and AIDS and those things. And I know the US, there was some issue of vaccine workers being used as informants in Peshawar, in the northern part of Pakistan there, which will also pose a problem. And I think there's a book written by a woman in the US whose father was a doctor. She was hesitant. She wanted to get vaccine, but a lot of friends were very hesitant. And she wrote this book, I can't remember the name now, but she spoke about the issue of there's this thing called neoliberal mothering. So when the parent come to you, is what you're saying, we have to engage them in a different way. They will be asking a lot of questions, and we need to be able to address it in a positive way and answer those questions.
Nice, thank you very much. Is there a way to adapt initiatives like the sort of antimicrobial stewardship initiatives into, and this gets after Tex, your sort of slide with the divide, into low and middle income countries or countries with lower resources, even in developed countries that don't have access to specialists necessarily, or to high efficiency laboratories like you were discussing? How do we move that sort of high-tech antimicrobial stewardship into a lower resource situation?
Again, that is one I would have passed, but I'll punt it again to Emmanuel, having grown up in Cameroon and now is in the high resource areas.
I think that's a really important question. I think we're in a situation where there are a lot of resource intensive interventions that are used in high income countries. And then there's inertia in low income countries in terms of there's not much, the thought that there's not much that we can do because we don't have resources. However, there is a lot that can be done in low resources, and when there's just willingness to do it, and also leadership to make it happen. The key things I think is having coordination at national and also at a continental level in Africa to improve access to drugs, antimicrobials first of all, and high quality antimicrobials, and also production of antimicrobials in Africa, which is CDC Africa and other stakeholders I know are working on. And secondly, it's also about education, simple things. Education about diagnosis and when to start antibiotics, when not to start antibiotics. And I think we need to roll out education programs, undergraduate as well as postgraduate education on stewardship and appropriate use of antibiotics. And then, although in Africa they aren't, because of lack of access to microbiological diagnostics and blood cultures and resistance results, that we still have data from research studies, their data from teaching hospitals with antibiogram data. And a lot of that data is not used, but it's available. It's not perfect, but it just needs a bit of effort to analyze the data and then use it as best as we can to make reasonable suggestions about what should be first line, second line for specific infections. And that's also work that I know CDC Africa and with other collaborators has also done at continental level. But that work can be done at national level to refine it based on antibiogram data from national level. What is available, it's not perfect. There are lots of gaps, but that can be done, or even at regional level and across hospitals. I think the future is in terms of diagnostics. I mentioned rapid diagnosis and point of care, and high-tech, costly blood cultures or other culture panels are not going to be available. What we need is low-cost point of care diagnostics that can tell us whether a patient with infection has potential resistant isolates, and then that may help change antimicrobial therapy. And I think that would be should be the focus of research, because we're not going to have enough resources to build expensive microbiological labs in rural areas or district hospitals. Just like what the Gene Expert has done for TB diagnostics and resistance, making it available at the health center level, where a sputum sample can be taken and drug-resistant TB identified within 1 hour. And that's a similar diagnostic, I think, that we need to develop for the future for rural settings in Africa.
But I think, Emmanuel, we got a bigger problem there, because sepsis is a disease of the poor. And in the rural areas and those things, there's no access to physicians. And many people are so poor, when they're given an antibiotic prescription, they get it for 2 days or 3 days only, or they get it and split it among family members, okay? So that is a major problem that I see, is really the socioeconomic inequities and disparities. And then in our world, we say, well, that they should be taking the full course of antibiotics, but they can't afford the full course. You go to some parts of the world and you see antibiotic shops, like little stalls, 10 or 15 stalls selling antibiotics and those sort of things, that it makes it a very, very difficult thing. So while you can do it in hospitals, most people who are getting treated out there are getting treated outpatients, and there is no control or anywhere to handle it. So I don't think we have a good answer for it. I think there are areas you can improve in the hospital setting, but I just despair. And we got to realize that sepsis is a disease of predominantly the poor. That's what it is.
Tex, thank you. That's the one thing I was struck by too, is health begins with water and food and shelter, and the ability to not be absolutely poor, so you can have a dose of antibiotics for 3 days or 5 days if you need it. So maybe time for one final question, then sort of revolving around that is, how does your average sort of healthcare worker, someone who's here today, who's frankly exhausted because there's been such turnover in healthcare recently after the recent pandemic, maybe exhausted from working too much, flirting with burnout after witnessing so much trauma, and flirting with burnout after the loss of trust from patients and families, and in the setting of sort of, I don't know how to say it politely, challenging discourse in our communities. How does that average person sort of lift up and support Global Sepsis Alliance, or contribute to advocacy, or help spread the word about the effectiveness of vaccines and the need for reduction in poverty across the globe?
Yeah, I think that's a very tough question, because obviously there's a Maslow hierarchy of needs. You take care of yourself first, you have food, shelter, clothes, you have comfort, and you take care of your physical and mental health. And then behind that, you will probably have some luxury time for initiatives like this. And I really, I would say, despair in a lot of ways because not many people have the bandwidth to do things outside the everyday sort of work. But that is what is needed in so many parts. But the issue of advocacy is there's the big A, global, but advocacy at a small level. And in fact, I challenge you to read any of the medical or nursing sort of, I guess, code of conduct. And a few years ago, I made slides of it. I read the nursing code of conduct, US, Canada, and all several other countries. And everyone has advocacy, again, advocacy for a patient, advocacy for this. So it's in our DNA, same as physicians. So you advocate at the local level, okay, and make the contribution that you can, small or large as it is, because that's the only way things will change. As Bill Gates said, he was commenting on this book, Polio, An American Story. He wrote on the jacket, he said, I am amazed what the great things that can happen when single individuals get together, okay, and support a movement. In fact, that's the only way the world has changed. And in fact, he was referring to the March of Dimes. It is one of the biggest charities in the US, but it started with women taking baskets and going and collecting dimes. So you can make, you know, in your little community and those sort of things, make us the contribution you can. In fact, I would say like right now in Canada, if someone asks me, I think one of the immediate things is to make contribution to food banks. Nutrition is very, very important. It's the best medicine. And when people are sort of undernourished, and when people are sort of don't have food, or their families don't have food, and it's a travesty that 1 in 5 children in Canada are sort of really on the edge, in other words, from the point of view of food. So that by itself, we can all contribute and make things better.
Thank you. And thank all of the three of you for having the vulnerability and the bravery to not only talk about hard science, but to talk about these really tough issues that face us. And I think, Tex, I like your philosophy, and I imagine all the people here today who've taken some time to improve themselves, think about each other and connect around sepsis are actually making a bigger difference than they think, and then they recognize. So I'm going to share just a couple things just as a reminder as we close our day. And that is, I want to say thanks, not only to our presenters, all of our presenters today, but thanks so much to the team that has made this possible, from the bigger organizations of Sepsis Canada, the Pacific Northwest Sepsis Conference, the Canadian Sepsis Foundation, UBC's Action on Sepsis, and Health Quality BC, as well as WISHA. And to the smaller non-organizations, but the individuals that I've had the pleasure of working with, who have both founded the Pacific Northwest Sepsis Conference. So 2 of them are here, Mary Jo and Rosemary, and to all of the people on the planning committee who have stood steadfast year by year on how to make this conference better every single year. One of my personal mottos is be brave, not perfect. And I think our team has done that. I do have one favor to ask of all the attendees. Give us your feedback. We want to know. We would love to know about how today worked for you. We'd love to know about what a sepsis conference, international sepsis conference that crosses borders should look like. Should it stay virtual? Should it be in person? What can you afford in time and money? what makes sense. And so please point your smartphone here at the screen and give us your feedback. We would love it. We'll also email everybody the link, but I'll leave this up for just a few moments. I really appreciate everyone taking time today to be with us and learn about sepsis and the engaging conversation and questions that I saw too. So please take a moment to read the chat. I'm going to turn off my video camera for a moment, but leave up this feedback screen for just a few more minutes. I look forward to seeing you all at our next encounter. So thanks everybody. Appreciate taking time for some feedback.